Good evening, everyone. On behalf of Dr. Mohit Shah and the Mumbai chapter of SFM, I invite you all for this, I would say, a special program with New Mumbai as the focus, and really appreciate the Mumbai chapter for taking this up as a with for the New Mumbai radiologist, fetal medicine specialist, and the obstetricians. Dr. Mohit Shah, unfortunately, is stuck up on the way somewhere. And so on his behalf, I welcome everyone. And to begin with, I would like to invite Dr. Ashok Khurana to, we're going to have one lecture and followed by 3 panel discussions. And to begin with, of course, Dr. Ashok Khurana, who is the immediate past president of SFM. He is the, you can say that he's the one who's actually started SFM. He's the one who has brought everyone together. He's brought everyone from every specialty who is passionate about the fetus all under one umbrella. And then you can see, how the society has progressed and how much education has been provided in the last few years from the Society of Fetal Medicine. So, Dr. Ashok Khurana, sir, can you please share your screen? And he's going to, we've given him a wonderful topic, and that is NT in 2020. So, NT in 2020 by Dr. Ashok Khurana.
Thank you, Bimal, and thank you for that wonderful introduction. I also want to add that it's really been a very, very heartening response all over the country and our neighboring countries as well, on how people have joined us in such large numbers to move together, irrespective of our specialty, to make sure that we give the best to each. And a few people were asking me, so is there a Navi Mumbai chapter? And I said, we used to go by numbers once upon a time. And then we said, okay, 10 people form a chapter. Then someone said 30, we made it 30, we made it 40. And then we realized, now how do we handle all this? Because there's so much talent and we're just brimming with talent. And we said we have to fit in everything. So Dr. TLN Praveen and me sat down and said, how do we handle this? And we said, we make study groups. That even if you don't have the requisite number, but you have the passion and the right kind of people there, you can all get together, irrespective of your actual specialty, and make a study group and have programs like this and make sure that all of us across the world get educated. Even in today's program, if you looked at the list, we are far more than just Navi Mumbai. We are pan-India, we pan Southeast Asia, and actually we have visitors here from the what I call the Russian satellite countries. That's the old-fashioned name for it from my time. And we even have a few people coming in from Spain. So that's very, very heartening. And let me now start with my talk. And it's going to be an interesting talk. It's a new talk I especially made for this program because I said we have to make sure that we let people know about the state of the art. And the state of the art is not just obtaining the nuchal translucency. The state of the art actually lies in the fact of using it correctly, because most of us have anyway learned how to do it. We no longer have to show images like this, which was the original image by Eva Pakiert from the Netherlands, who said in the first article that we ever saw that the nuchal translucency is the fluid accumulation behind the neck and that it is increased in Down syndrome and certain other conditions. We already now can appreciate this in our own embryos in 3D. And you can see that, yes, indeed, there is extra fluid here. But what we look at now is a 2D image, which is this one. And this is what gives us the image. But do remember that none of this happened overnight. The first image that was published on the nuchal translucency was 1992 and is this image here. And you know how we react when we see an image like this today. This image was by Kypros Nikolaidis. This image revolutionized the diagnosis of trisomy 21, and this image is respected for that. It may not be respected today, but it was the start. And today we've had to move beyond because he pushed us into moving beyond, and I'm glad we've all learned how to move beyond. So I'll take you through a historical perspective, a current protocol, updates of technology, both in genetics as well as ultrasound technology, the current status of NIPT, quality control, and some carry to your clinic messages, because we've come a long way. Even in the first years of NT, nuchal translucency, we were making lots of mistakes. In 1992, when Stuart Campbell came to India, he'd come to Agra, and we had images like this that we produced, and he was very pleased that we could do this. The entire fetus, no mid-sag, and generally we used to make an arrow and say, this is it. Some people still do that. That's not correct. But what we must realize is that, yes, even then we did realize that the nuchal translucency is separate from the amniotic fluid located between the neck and the amnion. So we did learn to differentiate that very early. We didn't do magnification as yet. And between 92 and 99, we were still making images like this. And this is from a Fetal Medicine Foundation textbook. And you notice that we'd probably not give this any clearance because there isn't enough magnification. But this is how things begin. And you must realize that images like this were the foundation of what we see today. But today we are highly evolved. And that's all thanks to Kypros Nicolaides, who has given us this technique of combining the nuchal translucency with biochemistry and giving us a 90% detection rate with a false positive rate of 5%. So let's go ahead and see where we stand today and why none of these pioneering images would be acceptable today, and what we should be doing with this information today. So if I take this right ahead from this point, let me show you that as of the article that came out in 2002, there was this very, very excellent conclusion saying that this is the way to go. And between 2002 and 2003, the entire United Kingdom and the United States had started to accept this, and they did realize that it was far better than the second trimester techniques. They used to give this wonderful image here, and this is still the best image going, and it's the best image to go by because it truly highlights what we still see. There are structures that are seen in this image that we never really realized were the anatomy that we see today. There was, of course, the bright bit here, which was the nasal tip, another bright bit, which was the skin, behind that, the bright nasal bone. The palate seen as a quadrilateral bright echo here, the midbrain here, that's where we were looking at intracranial translucency right behind the brainstem. And then, of course, the future cisterna magna right here at the back. And behind that, behind the occipital bone and between the skin was the famous nuchal translucency. So this kind of image from 1999 is the one that we now use today. And this is what is the state of the art. And let's discuss how we take this forward. Now, we've known Down syndrome for a long time. In fact, it was described first in 1862. And I want to, in 2020, tell you that don't lose heart that you're not recognized. Because when John Langdon Down told us about Down syndrome in 1862, nobody believed him, nobody bothered about him, and he had to repeat everything in 1886, 87 and say, look, this is Down syndrome. He used a politically incorrect word for today, which is idiots, but it basically did not reflect what we think of idiots today. It meant individuals with mental ability restrictions. And he was the first one to give us this description of what we now see as nuchal translucency. And that is that in addition to the face being flat and the nose being small, the skin is deficient in elasticity and gives the impression of being too large for the body. And this is what you and me picked up in the nuchal fold that Benasaraf told us about in the 1980s. And this is what we've been picking up now for the past 18 to 20 years. The fact that there was a genetic basis to this was, of course, a much later achievement, almost 100 years after Langdon Down first described it. And Jeremy Yoon, who was a pediatrician, told us that, yes, it's because of one extra chromosome. And that is when we said, okay, now we have to look for this. And that's where the story began. Now, it's very important to remind ourselves that trisomy 13 and 18, the other two common aneuploidies, have very minimal long-term consequences because they survive either not at all after being born or very briefly. And the other thing is that they have structural abnormalities, almost all of them, that help us to recognize them. However, identification of trisomy 21 is always based on subtle abnormalities of structure, which is why we call the nuchal translucency an ultrasound marker. and because of abnormal placental biochemistry, which is low PAPA and a raised beta HCG. Remember that these are called markers and they are non-specific, which is that they can be found in an abnormal or normal finding, and that has not changed. That the nuchal translucency thickness today does not define Down syndrome any more than it did when it was first discovered. Between 1992 and 2020, it still is a marker, which means it can be found at any thickness in a normal individual and at any thickness in a Down syndrome individual, and that we have to always incorporate it, and that will not change. That will remain the same since ever. We, of course, remember that, yes, all of this whole story started when we were looking for neural tube defects, and we discovered that for those patients in which the maternal serum alpha fetoprotein screening did not show an elevated but a lower value, those turned out to have a thick nuchal fold, and those were Down syndrome babies. And so therefore, that's where the whole story began, and that's where all these studies came in from. We had already realized that age is not good enough, because 70% of babies with Down syndrome are born to mothers who are less than 35 years old. And which is why in the 1980s, the triple test was invented, which rapidly gave way to the quadruple test, because the triple had only a 65% detection rate, and the quadruple had actually a 75 to 80% detection rate. We then went on to, like I described, the combined screen, which is nuchal translucency plus biochemistry, and we got a 90% detection rate. And then, of course, along came cell-free fetal DNA with a 99% plus detection rate at a very, very low false positive rate. And we thought, okay, that's the end of the nuchal translucency. But every year since 2011, the nuchal translucency has become more and more significant. And why is that so? It's because that just the way the nuchal fold give way to the nuchal translucency, we have realized that NIPT is very accurate, that the detection rate of trisomy 21 is greater than 99%, and the quoted rates are 99.6 to 99.9% from by different workers. But, all of this still depends on the identification of how much free fetal DNA in the maternal circulation comes from the fetus and how much comes from the mother. The word fetal fraction is a misnomer, because actually in NIPT, we don't look at fetal DNA, we look at placental DNA, but these two words are used interchangeably. And in the maternal circulation, we have maternal DNA and we have fetal or placental DNA. And if the amount of fetal DNA is less than about 8% originally described, or 4% in the newer tests, then the detection rate of NIPT goes down. And what does this placental or fetal fraction come from? Where does it come from? Well, the fact is that if you have a mother with a higher BMI, she will have a lower fetal fraction. And if you have a lesser duration of pregnancy, she will have a lower fetal fraction. If you have an altered number of fetuses, and whether the fetus is alive or not is equally important, because that reduces the fetal fraction, and interpretation then becomes important. And therefore, you need to know the duration, the number of fetuses, and whether the fetus is alive or not. And what do you need for that? Of course, you need an ultrasound scan. And if you're doing an ultrasound scan and you're figuring all that out, then you may as well also try and look for more important conditions, not just dating a pregnancy and to find out number and viability, but also to look for more common things such as structural defects, to look for a more common threat. As you see from this chart, Down syndrome is not as common as preeclampsia, is not as common as fetal growth restriction, is not as common as preterm birth. So what should we be looking for? Of course, we should look for Down syndrome, which is the most common cause of mental retardation out of the congenital ones. But we should also be trying to look for other things as well, identify them early, intervene early, prevent preeclampsia, and all that is happening. So there's no question that as of today, we do need an ultrasound scan before an NIPT, and therefore the nuchal translucency is here to stay. And this was a beautiful article last year that summarized this, and it was from Francesca Bardi and had some very big names from the Netherlands, which clearly said that we must do it because that will guide our further testing. It's not just Down syndrome we're looking for other additional things. And if we ignore the nuchal translucency, we're going to miss out a lot on what we can achieve in first trimester screening. And since the whole idea is to make as complete a diagnosis about the fetus, not just mental retardation, one of the causes of mental retardation, but actually things that are important for the fetus from another perspective and larger perspective also. And therefore the importance of the NT, even in 2020, we haven't gotten rid of it. Also, we've realized that with a thick NT, the choice seems to be invasive testing, and the noise we used to make about the miscarriage rates is not really true. And last year we had this brilliant paper from Laurent Salomon, and he told us in the White Journal that, look, the miscarriage rate in good hands that are well practiced and do at least 50 to 100 procedures a year is negligible. And we had another paper just last month saying that the miscarriage rate is actually the same as the baseline rate, baseline risk of that pregnancy for a miscarriage. So if you have somebody with a low PAPE, then they would miscarry anyway. If you had an abnormal fetus, there's a higher chance of miscarrying. And therefore, we should not worry about the miscarriage rate, and that when we see a nuchal translucency, we take it to its final, which means not terminate on the basis of a nuchal translucency or ignore the nuchal translucency, but happily and confidently carry it to the next step. This is one of the biggest steps we've taken in the last 2 years, and that is that we can take each nuchal translucency to its final diagnosis, not just a finding, but an actual diagnosis. And that is the difference between screening for one condition and confirming another condition, and therefore the importance of nuchal translucency even today beyond aneuploidies. Now, we've known for a long time that first trimester diagnosis is superior to second trimester diagnosis. That first trimester diagnosis is also superior not only because it is more accurate, but also because it gives the patients a chance to accept the possibilities. It gives us enough time for genetic testing. It gives us enough time for counseling. It gives us enough time for the patients to make up their mind on what they want to do with their lives. After all, some people would like to carry on with that pregnancy, and some people might opt to terminate that pregnancy. And that is a patient choice, not something that you and me decide. To destroy a fetus is a patient choice. That choice is not by you or me. We are not God. We are individuals to facilitate patient decisions. We are not people to impose decisions. But coming back to the point is that we try and aim for a first trimester screen, and the essence of that aim is a nuchal translucency. If we use just a triple test, second trimester, we have only a 65% detection rate, completely unacceptable from the ISPD criteria today. When we look at the quadruple test, again, just about 75% and touching that 75% minimum, although a well-done quadruple might even go up to 80%, but that's a borderline test. If I look at nuchal translucency alone, I am still borderline, and therefore I would be intelligent to combine NT with biochemistry, and I would be stupid to actually combine maternal age with only biochemistry, because that again is less than 75%. So that is the important bit. Also, when I'm running my ultrasound scan and I have the expertise and I have the time, I should run additional features as well of nasal bone or tricuspid flow or ductus venosus flow, because they enhance my detection rate for trisomy 21 to 96%, and they reduce my false positive rate. This has been reiterated over the last 2 years, and as of today, this is important, especially in the Indian background, because our patients believe that a test should be 100% accurate. They refuse to accept biology as biology. And therefore, we owe it to them to either counsel them extensively or at least give them a test that is closer to 100% rather than 90%. So when we reduce the 5 to 2.5%, we're actually doing them a good job. And so part of nuchal translucency evaluation today must, if possible, given the time and the pressures of work, include the nasal bone or tricuspid flow, ductus venosus flow. And if your institution is not doing that, specify that to the patient during their pre-test counseling, give them a written note on this, and let them then decide whether they want to come to your institution or go to another institution where this is actually done in that manner. Because that is the correct way to counsel, and that is the correct way to use the nuchal translucency, not just maternal age plus fetal nuchal translucency, because I'm good at the NT. The NT in 2020 has to be taken in its complete perspective. This is to highlight, again, that the triple test is not a reliable test, and anybody who is a member of the Society of Fetal Medicine should realize that this is eyewash, that this is cheating humanity, and because it doesn't match up to 75%, we should not be recommending or doing a triple test. If we get a triple test report, don't forget to pick up your phone and inform the person who actually prescribed that look, sir, look, madam, this is not the way to do it today. We know that the best way to do it if the patient is a presenting date is a quadruple test, but preferably a first trimester screen. And in that also, not just biochemistry, not just nuchal translucency, but a combination of the two, because today that's what NIPT is all about. Remember that we never use it alone. We always combine this reading with the CRL and the background of maternal weight, ethnicity, which is whether their skin, as Kypros Nicolaides says, is yellow, brown, black, or white, which he actually means referring to people of African origin, Caucasians, South Asians, and Eastern Asians, and also whether there's IVF or not, the number of fetuses, diabetes mellitus, and smoking. Then we add on the additional ultrasound parameters and we add them on intelligently. For instance, we no longer use the facial angle. Why don't we use it? It's not sensitive enough. It doesn't add in any way. So it was dropped several years ago. Why don't we use the hepatic artery? A lot of us took a lot of pains to try to do it. The fact is that the hepatic artery is difficult to do, that the ductus venosus is easy to do, that the hepatic artery performs exactly like the ductus venosus, and therefore I shouldn't be doing it. But should I do the ductus venosus in addition to the nuchal translucency? Yes, because the ductus venosus is an additional parameter. It tells me more. It tells me more that yes, this is the way I should be doing it. It tells me for sure that even if the nuchal translucency is normal and the ductus venosus is abnormal, it could be trisomy 21. It could also be cardiac defects. It could also be all kinds of other things. But the fact remains that the one thing that I'm looking for is a better diagnosis of my perspective of the nuchal translucency. Now, I know that there is nothing that has changed in crown rump length as far as we used to believe, and we still think that 45 to 84 is standard. But the interesting thing is that as of today, we no longer confine ourselves to this, because we had a very interesting paper a couple of years ago, and that told us that we can actually measure the nuchal translucency at a crown rump length of 28 to 44 millimeters. This paper by Tony Borrell's group has been lost somewhere in time. It came out 6 years ago, but it actually tells me that from 28 millimeters of crown rump length all the way to 44, I still have a 5th, a 50th, and a 95th centile reading. Is it as significant? It might be, because some of these will disappear and never appear again and might have been the only sign of trisomy 21. Some of these remain and may not be necessarily just trisomy 21, but there could be cardiac defects as well that decompensate much earlier than the nuchal translucency cardiac decompensation with lymphedema that happens at 11 to 14 weeks. Therefore, it's well worth it to realize that we can measure, if we have the right section, nuchal translucency at 28 to 44. So in 2020, we will start using this so that we get our eyes tuned and so that we get our head tuned as well. Now, but otherwise, in that time of 11 to 14 weeks, when should we do this? If we look at biochemistry, there are two components, beta HCG, which remains the same. The elevation of beta HCG remains the same from 11 weeks to 14 weeks. But PAPE, which is low, is much lower in aneuploid fetuses at 10 weeks compared to 13 weeks. Therefore, ideally, we should be doing biochemistry at 10 weeks. For the sake of the patient, we say, okay, one visit, we do it in one visit, we do it at 12 weeks. But the fact is, then should we do it at 11 plus, at 12 plus, or at 13 plus? Look at the difference in anatomy. This is 46 millimeter crown rump length, and this is 66 millimeter crown rump length. How much more anatomy do we pick up? A lot. Do I depend on that anatomy? A lot. Does it add to my diagnosis? A lot. And therefore, I should be doing the NT as much as possible at about 12 weeks, 4 days, 12 weeks, 6 days, as much as I can do it. There's no doubt that in India, people walk in at random. But if you're not really satisfied, you can say, I'll postpone it. Don't get worried about the patient running away. Your name will not run away. And that is more important, that your dignity of the profession has to be maintained rather than your cash jingling register at the end of the day. And therefore, I suggest that we wait for at least a 63 millimeter crown rump length before we add on the rest of the parameters, including the nuchal translucency. Do I wait till 13 plus? You can, but the fact remains that it does take a while for the time factor, the genetics, then that you don't have that first trimester advantage. And so I'd rather do it everything, if I can possibly do it at 12 weeks, 5 days, and not earlier and not later. Now, this crown rump length is as important as the nuchal translucency, and that has not changed. The way we do it is the same as before. And so I will not spend time on it, except to remind you that today, the Fetal Medicine Foundation accepts a post-freeze zoom. Previously, we had to zoom in before we did it, and it was supposedly illegal to zoom afterwards. That is not true anymore. You can zoom in afterwards. And the same applies to the nuchal translucency. Also, when we try and make the outline better, we can change dynamic range post-freeze, and we can change the gain post-freeze and then do it. So in 2020, post-freeze image manipulation is perfectly good. And then it's not enough just to measure. You have to put it onto a table, and we use tables just like we use no single cutoff, which means that the nuchal translucency is much less at 45 millimeters and much more at 85 millimeters, and we have to take that into account. The rest of the stuff, such as a cord around the neck and therefore measuring below and above, remain exactly the same. The caliper placement remains exactly the same. But do remember that calipers continue to be the plus ones and not some of the fancier shapes that have been added to some of the new machines. Please remember that this plus caliper is to be used and not something that looks like an H, and not something that's highly magnified where the edges get blurred. There is equipment now that magnifies the area where you're placing, but that actually distracts from the exact placement of calipers. So in 2020, use the old-fashioned caliper in the old-fashioned way. Circumnuchal cord, no change. You measure above and below, and you take a mean, and you get your answer. Automation, the new word, dirty word. Why? Because it's a technology before its time. One manufacturer says that get me approximately, and I will do this. When you look at what they reconstruct, half the time it's not even correct. And therefore, I will always end up with a zygoma between my nasal bone and my palate. And therefore, in 2020, I am not going to use automation. The other manufacturer is this one, which says that, look, you give me an image and I will measure automatically. And this is that little video that tells them what they do with it. The fact remains that this placement,
the new semi-automated tool for nuchal translucency measurements.
But more than that, what happens is that half the time it just goes wrong. You have to recheck it with your eyes. What I need in 2021 is that I have an approximate sagittal image. And in that approximate sagittal image, my artificial intelligence should be able to do an auto 3D, find the right placement and measure it correctly for me. That is what I expect in 2021. In 2020, I will always re-inspect automation and not believe in automation just like that. What about graphs? Two graphs commonly used, the Schneider's from many, many years ago, 18 years when it was revised, and the Sonoview, and both are equally good. However, there is a difference between the Indian NT and the Caucasian NT. In fact, there is a difference between the Swedish NT, the UK NT, the actual NT from Thailand, and these have been reported. But we've ignored this. This was a paper that we presented at an ISWAG meet in 2012 and actually showed that the Indian NT is a thinner NT than the Caucasian NT. And this holds true, but we never were able to expand this data because we were getting too busy at that time. And we perhaps should do it now as a community service from or community pooling of data from the Society of Field Medicine. But we've clearly shown that This was our NT chart, the darker one, and the upper lighter one was the international NT chart, which was the FMF chart. And this has been accepted by many. But the important thing is that because this was a smaller study, this was only 1,000 cases with completely followed up values, we've not been able to use it, but this is the way in the future. So beyond 2020, we need to pool our data and come up with a chart for, say, 500,000 Indians at least, or 2,500,000 Indians, and say, okay, this was normal outcome, and this was the NT at 11 to 14 weeks, or should I say the NT at 10 to 14 weeks, because now we will include NT after a much lower crown rump length. The other thing to do is that today, you cannot move ahead in NT in 2020 without audit. What is the difference between these three graphs? These are audit graphs where you keep sending your NTs to centralized agencies such as the Fetal Medicine Foundation. And if your NT plot is like this, equally distributed between the 50th centile, the 5th and the 95th, that is normal NT measurement. Here, most of the dots are below that 50th centile, and therefore this is an underestimating operator. This individual tends to underestimate NTs. This individual tends to overestimate NTs. We have a joke that people who like to do invasive procedures fall into this category, and people who like to do invasive procedures fall into that category. But that's not the way to look at it. The way to look at it is this, that we should get this particular thing, and therefore we need it. What we also need is certification. Currently, the Society of Fetal Medicine is not, we don't have enough manpower to do this, but somewhere in the future, we would think that just as the Fetal Medicine Foundation is looking at it, we would do it, but we'll have, of course, stricter criteria. We've also introduced two things at the Society of Fetal Medicine. One is that we've had a first trimester quality control on-site program, and our president, Dr. TLM Praveen, is now devising a virtual program for the same thing, which is an instructional demonstration program for a day, where we will teach you how to do this or revise your technique. And more importantly, we will move this on to getting images from you so that you can be appropriately certified. We've also at the same time tried to sensitize clinicians by using a paperweight, which was by one of our trade partners, where we actually gave an image of a well-done NT. And so that clinicians could keep this on their table and say, okay, the image that this worker is sending me is the right image, and therefore this is the lab where I should be sending my NTs to. This is the ultrasound clinic where I should be sending my NTs, and not to those ones like those first images of Kyphros Nicolaides that I showed you. So auditing is important, but sensitization of our colleagues is again something that we are undertaking, and we're going to enhance it further in the years to come and not just stop at December 2020. Can we enhance this? Yes. And normally I don't like to take trade name, but the fact is that if on your equipment, you're using reporting software from either FetView or Tricify, and these are not inexpensive, you have to pay for them, but all your nuchal translucencies, if you click a button, will go directly to the Fetal Medicine Foundation, where free of cost, they will be audited for you. And that will ensure that you're doing a good job. Because when someone else is looking at your image, you will always do a good job. Because sometimes we compromise. We say, okay, so-and-so waiting, so-and-so waiting, so many people on my head, this patient will beat me up, this patient will destroy my clinic, this will destroy my furniture, this one is MP, this one is income tax, all that. No, we must do it correctly. We must share it with an authority, and FetView software and Tricify do that for us. And of course, we continue distributing our paperweights. What do we do with these models? We've changed things around a bit. Age, not recommended. Hubbard crown rump length and NIPT, ideal for the first trimester, but misses the advantages of screening for anomalies and screening for preeclampsia. Also, it's expensive and therefore not the best option. Age, crown rump length and NT, 80% sensitivity, requires a lot of skill, but only 80% sensitivity, not the best. Age plus biochemistry, 65 to 70%, poor detection rate, not acceptable. The standard of care today for population screening is age, crown rump length, maternal factors, NT, PAPE, and HCG, called the combined test. That's the way to do it. Enhance it to what we should be doing in 2020 to reduce false positive rates and enhance our detection rate. What I mentioned, was add on additional ultrasound markers. They take more time. And some people like to use it in a skilled manner. That means you find an intermediate risk, you then do the additional markers. But ideally, because a lot of us come from a population of private practice, we should add on these additional markers so that the degree of false positives goes down and our sensitivity goes up right from the beginning. And of course, we will always use biochemistry. There are people who say you can dismiss biochemistry or use it as a secondary way to do it. The fact remains that that is not good, because then you're depending on a single operator for your NT. And if that person made a mistake, your NT in 2020 is crushed to being the NT of pre-2002. That's not acceptable. Can you combine first trimester with second trimester biochemistry? Yes, you can. And that's called sequential if you give out the reports, or integrated if you put them all together. That works, but again, only 80 to 90%. What works better are additions to your NT algorithm if you add on additional biochemistry. There is one called the T1 quadruple test, where the add-on is PLGF, which tells you about preeclampsia, and alpha-fetoprotein, which adds on your risk for NTD. And therefore, it's a useful thing, and it enhances the detection rate for the trisomy 21. If, however, you add on to the NT a nasal bone, plus one more in addition to alpha-fetoprotein, the dimeric inhibin A, your detection rate goes up to 98%, and your false positive rate goes down to 1.2%, and therefore that seems to be a great alternative as of today. Not widely available, but that's the sort of stuff we look forward to, using more of the T1 quad and more of the T1 penta to go ahead, and also to the extent possible, unless you're really pressed by populations and equipment and funding and expertise, then we will use just a simple combined test, which is the population test. Now, the risk groups currently that we use in 2020 for further calculation are the same as we were using in 2019, which means a risk of greater than 1 in 10, you offer invasive testing. Greater than 1 in 50, we offer NIPT or invasive testing and let the patient decide. If you have a risk that is less than 1 in 1,000, that's the low risk. You just send them off and say, come back for a anomaly scan, and we will do genetic sonogram at the same time. The ones in between, where NT plus biochemistry give you a risk of 1 in 50 to 1 in 999, are called intermediate risk. And this is where you either add on the other ultrasound markers and recalculate, or you offer them an IPT and let the patient decide. Remember, we offer this as a cafeteria approach. To that, nothing has changed in 2020. It's the same as it was before. Cutoffs can change, because sometimes Kyphros Nicolaitis, whom I respect very much, and he always goes by statistics, which is fantastic, tells us that let's this year use 200 or 300. We follow that. As of now, he's told us to use 50 to 1,000 as intermediate, and that's what we are using, and that's the way we should be going ahead. So as of 2020, we use 1 in 50 to 1 in 1,000 as intermediate risk, but you're entitled to use whatever you believe in, because that group then has to be offered cell-free DNA. And if it's positive, you must confirm the diagnosis of trisomy 21 by invasive testing. And if it is negative, you go back to the low-risk group, and therefore you're happy. If the patient doesn't wish to do any of these and says, okay, no, I will do now amniocentesis, that is their choice. And that you allow them to do. Or they say, no, I will make up my mind only at 18 weeks. That is also allowed for them to do, because the ultimate decision is of the patient. Remember that if you happen to see a nuchal translucency, an omphalocele, a megacystis, an AVSD, tetralogy fallow, or those things that are very common in the aneuploidies, you will move straight to invasive testing, and then you will disregard your total biochemistry, etc., even if it is low risk. If it is high risk, it encourages you. But even if it's low risk, that's fine. Some patients may still not agree, in which case then you postpone the decision and say, okay, come back at 16 weeks. But ideally speaking, encourage invasive testing. And remember that each time when you talk about encouraging, it's not that you say, you will do this. You will say, no, this is what is available. What would you choose? They will say, doctor, you decide for me. You say, no, I'm not in your position. You decide. The counseling remains the same today as it was originally formulated 18 to 20 years ago. Now, remember also that today we are even more aware of the fact that there is much more to the nuchal translucency than just aneuploidies and trisomy 21. We have cardiovascular defects, very, very common, pulmonary defects, skeletal dysplasias, congenital infections, and metabolic and hematological disorders. And the thicker the NT, the worse the chance of major fetal abnormalities. And therefore, you need to look at this very carefully. Remember also that there is this wonderful article that came out in June this year telling us the cutoff. Traditionally, we play around until we see a 3.5 millimeter cutoff because that's where the bulk of the abnormalities lie. And therefore, we were encouraged by the Fetal Medicine Foundation to say, this is what we should be doing. However, there is a significant number of aneuploidies and other abnormalities between 3 and 3.4 millimeters of an absolute value of NT, not gestation age related, but absolute value. Then what do you do with these? And look at the big names that we have here, really, really big names. And they said that, look, maybe it's a good idea to use 3 millimeters as a cutoff because of the high risk, 1 in 7.4 for a chromosomal aberration in this group of between 3 and 3.5. Because if you were to give them that dilly-dally, should I do NIPT, should I not, and they were to opt for an NIPT, that's 2 weeks, another week for making up their mind. Then that brings you to 14 weeks, which is neither here nor there. You have to wait for 16 weeks for invasive testing. And therefore, it's a wise idea to start thinking at 3 millimeters. Can we think at below 3 millimeters? What should we do? And so we have this paper from China at the end of last year, which is why I've included it in this 2020 talk. And on the value of an NT greater than 2.5 at any period of gestation. Here again, they said that, look, not that we can use 2.5 as a cutoff, but if you are doing an invasive procedure for whatever reason, such as an abnormal combined test, and the NT is more than 2.5, you do one rapid test for trisomy 21, but you also add on a CMA because that CMA will help. So even at the lower end NTs, which are not above the 99th centile, you start thinking of invasive testing. You start thinking not of just trisomy 21, but a chromosomal microarray because it will give you more information. That is where we stand in using the NT. The way we obtain it is the same as before, but the way we use it is quite different. Remember that at less than 95th centile, the chromosome defects is very, very few, and most of them will be alive and well. But between the 95th and the 99th centile, we don't want to miss this. And therefore, we will try and pick this up. And therefore, we use a cutoff, which is 3 rather than 3.5, or even better, in 95th centile for that gestational age. So what I use currently in December 2020 is the 95th centile for that gestational age in the absence of any other finding. That is what we start encouraging thinking of invasive fetal testing. Of course, the thicker it becomes, the higher the chance of chromosomal defects, the higher chance of stillbirths, and the higher the chance of other fetal abnormalities. So we always combine the NT with a very good anomaly scan. And invariably, when you have this finding, always do a transvaginal scan. Don't just stick to a transabdominal scan. The bulk of NTs today are still measured with a transabdominal scan. That has not changed in 2020. We've known for a long, long time that nuchal translucencies which persist up to 16 weeks need to be investigated more seriously, because those abnormalities may not show up in a QFPCR. They will not show up in a microarray. They will not show up in a conventional karyotype. They will show up as one or more groups of gene defects. And the classical example is Noonan's. Noonan is a conglomerate of gene defects. It's monogenic, but the number of genes involved is large. And therefore, if you have a persisting NT, then the rule today in 2020 is that any NT which is clear like this and you still have a nuchal edema, start thinking Noonan's, and you then do either a Noonan gene panel or shift them straight to exome sequencing, and then you have your answer. So in 2020, the NT does not work with ultrasound alone. It works with the clinician, it works with the patient, and as a geneticist, as the fourth end of that wonderful quadrilateral that will then give each fetus its best outcome. Remember also that the NT mid-sag is no longer the NT mid-sag. You have much more. You can see the brainstem, you can see the the intracranial translucency, you can see the cisterna magna, and therefore You can pick up open neural tube defects. You can identify occipital cephaloceles and early identification of cystic abnormalities in the posterior cranial fossa. Not that you will terminate on the basis of this finding. No, you will do a complete anatomy scan, but these are clues within that same image. Also within that same image, you must understand that we can pick up the obliteration of the intracranial translucency, and therefore this is what that would look like. And that is something that we truly should be doing. Remember that for all of these, the original rule of entry remains today as it was 20 years ago. You need to be patient, you need to wait, you need to get the right image. You can't have scraggly images. You will do a vaginal scan where necessary, although a transabdominal is easy to manipulate, and you will wait patiently till you get the absolute right answer. And the moment you spot something like this in the posterior cranial fossa, start thinking a Dandy Walker malformation or something more. Don't terminate, but call them back for an early morphology scan, all in the same mid-SAT section that we use for our NT. And it's not just that particular finding. There are additional findings as well, such as this described by Simon Ma last year. And what they showed us was that if you draw a line along the mandible, right along, and you take it across the brainstem, you will find that in neural tube defects, the bulk of the midbrain lies below that occiput maxillary line. You don't even have to identify the occiput. You just draw this line straight across the top, and you will then, in your NT plane, be able to identify a neural tube defect in a far more sensitive fashion. This is their translation of their so-called axial view, where they find thickened cerebral peduncles and backward displacement of the parallel cerebral peduncles and a backward displacement of the aqueductus sylvius. This is the equivalent in the SAT view, and this is something that is worth looking at. Something that you now routinely do, just draw a line right across, and most of the brainstem should be above that line. We can also look at the maxilla, and we can look for maxillary defects. And this has been beautifully described by Ravi Shawi, and of late, exquisitely described by our member, Dr. Lakshmi from the south. And she has shown us that we actually see 2 bones here, and that we can identify many more, provided you combine this with an additional view. Remember also that you can not only pick up maxillary gaps like this, which identify various types of palate, but also pick up retrognathia and micrognathia, because if you draw a straight line connecting the front of the nasal bone to the front of the palate, and you find that the magnification of the mandible is behind that, that is retrognathia. And as long as the mandible is in front of that, that is not retrognathia. So a great test in the same image as the nuchal translucency. May I remind you once again that we don't look just at the centile, but we look at absolute values still to encourage us towards guiding us for invasive procedure, towards guiding us for CMA rather than conventional karyotype, and for going on to whole exome sequence, because then you really get some excellent diagnoses, as much as 80% for a thick nuchal translucency. So the story so far: in the economically privileged patient in 2020, the first trimester screening should include an 11 to 14 week complete assessment and a first trimester combined screen plus PLGF for placental function plus NIPT. Not all our patients are economically privileged or want to pay for it. Population screening, first trimester combined screen, which is NT, PAPE, beta HCG, but quality controlled. And anything less than that is an institutional protocol, is a compromise. And therefore, you need to tell your patient about that, and you might be compromising because you don't have equipment or time or the funds. If you find a structural abnormality, encourage invasive testing. That, if you're doing an invasive testing, say for any other condition such as thalassemia, then always add a QA-PCR for aneuploidies. And I want to remind you that the story of ultrasound and genetic technology has only just begun, and we look forward to much more in the year ahead. And thank you so much for your attention.
Thank you so much, sir. It was a wow presentation. Though we know that the widespread use of NT began only in 2003, but I was very curious to know what you would be talking today, and your lecture was full of take-home points. Amazing take-home points So we know how we've evolved in this 17 years from 2003 to 2020. Thank you so much.
Thank you.
Moving on, today's webinar is unique in the way that all the presenters today are of younger generation, resonating with the view of Dr. T.L.N. Pravin and Dr. Ashok Khurana that we need to encourage young speakers. So all the presentations that you're going to see today are pertaining to the topics that you would see in your clinical practice in day-to-day life. But all the presenters today are young presenters, and we have a fantastic panel, which is a perfect blend of seasoned senior panelists, along with, again, a younger generation who's probably on the panel for the first time. The moderators, all the three moderators need no introduction, but I have to introduce them for the sake of formality. As we start with the first panel, which is going to be headed by Dr. Bimal Sahani. Dr. Bimal Sahani is a radiologist from Aurangabad who practices exclusive fetal ultrasound. He is the president-elect of SFM. He is the brain behind the Scholar MD Fetal Medicine Fellowship and an excellent orator. So he is going to take the panel on borderline ventriculomegaly, and I hand it over to Bimal to introduce the speaker as well as the panelist. Over to you, Bimal.
Thank you, Mohit. At the onset, really would like to thank Dr. Mohit Shah and the New Mumbai study group for putting this all together and giving me an opportunity to be a part of this wonderful meeting. We start with this thing with a case presentation on mild ventriculomegaly by Dr. Kakuli. She is going to take us through. She is an alumnus of the Tata Memorial Hospital, and she's been practicing in Navi, Mumbai since last 20 years. A very, very, a fluent speaker and a very talented person. And Kakuli, can you share your slides? And then after that, we'll begin with the panel there.
Dr. Kakoli, are you on?
Yeah. Am I audible now?
Yeah, please. Yes.
Yeah. Should I start?
Yeah, please do.
At the outset, I would like to thank the Society of Fetal Medicine, Dr. Khurana sir, and the whole team for giving us this opportunity to present our cases before this esteemed forum. Today, I'll be presenting a case on mild fetal ventriculomegaly. A 34-year lady, second gravida with a previous full-term normal delivery 8 years back, comes to us for a mid-trimester TEFA scan. Her corrected gestational age was 21 weeks based on a dating scan done outside. No history of consanguinity, no history of travel, non-smoker, non-alcoholic, no history of any genetic disease. The dating scan done at 6 to 7 weeks was unremarkable. She had not done the 11 to 14 week scan, no first trimester screening during the pandemic. However, we had a quadruple marker done at 18.1 weeks, which was screened negative with low risk for Down syndrome and Edwards syndrome. The biometric measurements well correlated with the gestational age. The head parameters, the abdominal circumference, and all the fetal long bones did not show any deviation, and it correlated well with the gestational age. However, on the structural scan, we found that the fetal atrium of the fetal ventricles were dilated bilaterally. The right atrium measured 10.8 mm and the left atrium measured 10.9 mm. At this point, we had taken special care to recheck the measurement, keeping in mind the measurement guidelines, and we found the measurements to be the same. This prompted us to do a fetal neurosonography to evaluate the brain in the sagittal and the coronal planes as well. And here we see a normal shape and size of the cavum septum pellucidum, the thalami, the cerebral peduncles, the cerebellum, the cisterna magna, nuchal thin fold. In the coronal plane, we could see mild prominence of the frontal and the occipital horns. The mid-sagittal sections show the well-formed corpus callosum with the pericallosal artery coursing over its entire course, the third ventricle midbrain and the fourth ventricle well seen. The spine was evaluated in all the three orthogonal planes. Here we see the coronal plane where we do not find any fusion anomaly, any spinal dystrophism, kyphosis, scoliosis. The axial planes were evaluated from the cervical region to the lumbosacral region, and we did not find any separation of the posterior elements, and no lateral mass separation or any cystic mass was seen. Special care was taken to evaluate the spine with high resolution sonography in the lumbosacral region. This was keeping in mind that the alpha fetoprotein was normal in the quadruple marker, and thereby the possibility of a closed neural tube defect was always there. So here we can see a conus medullaris well seen the phalum terminally, and so surface reconstruction was also done to look for the skin and subcutaneous tissue in the lumbosacral region, and all appeared perfectly normal. A detailed fetal echocardiography was done, and here are the four major planes to document the same. The structural evaluation of the entire fetus was done keeping in mind the ISWAG guidelines and in coordinates with the ISWAG guidelines, and we did not find any anomalies so far in the fetus. The placental width was normal at the level of cord insertion, and the Leica levels were adequate. Incidentally, we found the succensurate lobe in the placenta and an amniotic self in the Leica. Based on this, we formed a provisional diagnosis of bilateral mild symmetric ventriculomegaly in a fetus with normal biometry and adequate Leica and no other structural abnormality. At this point, we counsel the patient saying that mild ventriculomegaly is just a finding, and this could be associated with aneuploidies or other chromosomal abnormalities, fetal infections, mainly cytomegalovirus and toxoplasmosis, and also there could be other cerebral or extracranial abnormalities which could be detected at a later date or even postnatally. Based on this, we advise the patient to go for amniocentesis and chromosomal microarray, a torch assay of maternal serum or amniotic fluid. Patient, however, refused to go for any invasive testing and comes back at 25.6 weeks with a normal maternal torch assay report. At this point of time, we rechecked the ventricular atrium, and we found that the right lateral ventricle showed an atrial dilatation of 11.2 mm, which had mildly increased from the previous measurement, and the left lateral ventricle had also increased mildly to 11 mm. This again led us to do a fetal neurosonography. However, we always wanted to do a TVS sonography, but keeping in mind the poor fetal position and the peak of pandemic, we had to do an abdominal neurosonography. Special evaluation was done at this point of time to look for the vermis. The CSF pathway was well seen, the tentorium well seen. The sulcation, the sulci of the brain, the ones which were to be developed now at 26 weeks, were well seen. We could see the Sylvian fissure, we could see the calcarine, the cingulate sulci well seen. The operculization process of the Sylvian fissure was also noticed, and special care was taken to look for the ependymal lining of the brain, to look for any echogenicity, calcification, nodularity, thereby ruling out the possibility of gray matter heterotopia and also germinal matrix hemorrhage. The coronal and the sagittal planes also did not reveal any other abnormality besides the mild ventricular dilatation. The fetal biometry at this stage was also normal. There was no evidence of any microcephaly or macrocephaly, and the growth curves were absolutely normal. At this point, we again counseled the patient saying that the ventricular dilatation has mildly increased. But however, the prognosis for this patient remains still the same because we did not have any workup done for the patient. Going ahead, these findings might regress, remain stable or progress through the pregnancy or even postnatally. At this point of time, we advise the patient to go to look for the cranial abnormalities which might have been missed at this point of time because of the technical error or for the limitations of ultrasound. Patient, however, refused to go for any of these investigations, and the patient delivered, and we lost a patient to follow-up. Few months later, 2 months later, the lady delivered a full-term normal baby boy, and till date there has been no report of any neurodevelopmental delay or structural abnormality in the baby. With this, I would like to end my presentation. I thank all the dignitaries and delegates for a very patient hearing, and I hand over the case to the panel and Dr. Sahani sir for the panel discussion. Thank you.
Thank you very much, Kakali, and uh, very nicely taking us through the case and wonderful images. Just love the images here. I'll be sharing my screen now. Okay, there we have. Okay, I'm full screen now. Thanks a lot, Kakuli. Please don't go away. You are a part of the panel also. And we're going to, in the next 30 minutes, we'll go through a few practical aspects of what we do next when we see ventriculomegaly. And I have been given a wonderful panel. Of course, Dr. Kakuli Borthakur, I've already introduced. She is a radiologist with special interest in fetal medicine, practicing in Navi, Mumbai for 20 years. Then we have Dr. Hemangini Thakur, who is the professor of radiology at KM Hospital, a very multifaceted radiologist, again with passion towards the fetus. She's got multiple publications and book chapters, and she's associated with multiple research projects as a co-investigator. We have Dr. Sunita Malari from Navi, Mumbai. She's a consultant radiologist and HOD of radiology in Fortis Hiranandani Hospital, Navi, Mumbai, again with a special interest in fetal medicine and practicing in Navi, Mumbai for the last 15 years. Dr. Rahul Wani is a practicing obstetrician and gynecologist. He is an honorary consultant at Mathadi Hospital Trust, and he's practicing at Archana Maternity. Another feather to him is that he's done his law, and so he's an obstetrician with a medical legal background, and that is why he's associated with a lot of medical legal consultancies, and he's been a member of the ethics and the medical legal committee of FOXI, and he is the president-elect of the Navi Mumbai OBGY Society. And then we have Dr. Priya Deshpande, who's an obstetrician with fellowship in fetal medicine, and she's practicing as a consultant in fetal medicine at Motherhood Hospital and Apollo Hospital, Navi, Mumbai. She's a faculty at the Fetal and Gynae Imaging, that is the FGI course programs that we see, and she's also the treasurer of the Association of Fetal Medicine Consultants Maharashtra. And lastly, to give us the genetic perspective in whatever we discussed now, we have Dr. Chaitanya Datar, who is a genetist, and he's a program director at Sujanan Clinics. He's got 12 years experience in this field. He's got about 100 lectures in Indian and international conferences. He's got 24 publications and 4 book chapters to his name. And then again, he has a special interest in dysmorphology and metabolic disorders, neurogenetics, prenatal diagnosis, fetal autopsy, and NGS and microarray data. So thank you, Dr. Mohit, for giving me a very wonderful panel. With one thing which I can see about all these panelists, there is one thing which is very common amongst them, is that they're all very passionate about the fetus. And that augurs very well in a program of a Society of Fetal Medicine, which actually is where we all want to give an optimal outcome to the fetus. So we start with the first question to Dr. Hemangini. How do you define ventriculomegaly and how do you grade it?
Good evening, everyone. Before we define ventriculomegaly and grading of it, I would like to emphasize on 2-3 points, though they are very basics, but it is very important. First is, when we say that there is a ventriculomegaly, we are referring only to lateral ventricle and not third or fourth ventricle. If third and fourth ventricle are dilated, it is measured separately and it is mentioned separately. Second point is, ventriculomegaly is a finding and not a final diagnosis. Like when we do our abdominal ultrasound, we say splenomegaly. So that is the finding. That way ventriculomegaly is the finding. So when we conclude our report or when we write final impression, only mild ventriculomegaly should not be said. We should try to write the etiology if possible in our diagnosis. Now coming to the ventriculomegaly, as we know that ventriculomegaly is excess of fluid in the lateral ventricle within the developing cerebrum. So we know that from 15 to 40 weeks, the ventricle size remains more or less constant, that is from 6 to 8 millimeter. So when it increases 10 millimeter or more at the atria in the transventricular plane, when we measure in the second trimester, we call it as a ventriculomegaly. Another way to define ventriculomegaly is separation of 3 millimeter or more of choroid plexus from the medial wall of the lateral ventricle. If this is more than 3 millimeter, also we can call it as a ventriculomegaly. Now we see the grading of the ventriculomegaly. So it is 10 to 12, mild, 13 to 15 is moderate, and more than 15 is the overt ventriculomegaly.
Thank you, Hemangini. And actually, this is the grading that we used to follow long back. And in between, for a few years, there was a consensus which said that we need to divide it only between mild and overt. Mild was 10 to 15, and overt was greater than 15. But again, since the last 2 years, there have been studies which have shown that there is a difference between 10 to 12 and 13 to 15 as far as outcomes are concerned. And hence, we are back to our original grading. At least for the sake of counseling, we need to grade them, as Hemangini said, as 10 to 12 as mild, 13 to 15 as moderate, and greater than 15 as overt. Thank you, Hemangini. And thank you for those brief points in the beginning. They were very, very important. Now we move to Kakuli, because you've already presented a case. I want to ask you, see, the problem is, in my own practice, I've realized that at least 1/4 of the cases that are referred to me for a second opinion because of mild ventriculomegaly actually do not have a ventriculomegaly at all. So there is something which goes wrong. So what are the prerequisites for an accurate measurement of atrial width? So the measurement itself, the right section and the right measurement is very important before we label it as ventriculomegaly. So what are the prerequisites?
First thing we would like to measure, the ventriculomegaly and ultrasound is measured in the strict axial plane. So how do we ensure? The strict axial plane means the midline should be equidistant from the proximal and the distal calvarial margins. Once we have ensured that it's the strict axial plane, we want to see the bony landmarks. The bony landmark is anteriorly the cavum septum pellucidum and posteriorly the ambient cistern. Once we have reached achieved that, we want to keep the, of course, during the acquisition, we need to keep the focal zone at the appropriate level, and the atrium is to be imaged. We zoom the image properly. The next thing we want to see is the placement of the caliper. The caliper is to be placed on and on. This means that we place the caliper at the junction of the ventricular wall and the lumen, and the axis of measurement should be perpendicular not to the brain but to the ventricular orientation. So with this, we take the measurements of the lateral ventricle.
Where do you take that measurement?
We take the measurement at the level of the internal parieto-occipital sulcus, and which also corresponds to the glomus of the choroid plexus, which is the most echogenic part of the choroid plexus.
Yeah, so we actually need to learn. Even Dr. Palladini the other day was saying in the new guidelines that are coming, they have changed it to the glomus of the choroid plexus, because the parieto-occipital sulcus is something which we start seeing after 20 weeks. And we end up in a situation, because 99% of the TIFA scans that we do are at between the 18 to 20 weeks. And that is why we do need to measure it at the glomus of the choroid plexus. But what do you do when, because see, you can measure the distal ventricle very nicely. Is it important to measure both the ventricles?
Yeah, it's very important to measure both the ventricles. The measurement criteria for both the ventricles are the same. However, because of the shadowing which comes in the near lateral ventricle, we need to place the probe not in the at perpendicular to the midline, but at a 30-degree angulation, with the posterior part of the brain nearer to the probe and the anterior part of the brain away from the probe.
Very important thing. So we need to get our measurements right, we need to only then we are, especially a little error in getting a proper section, you can convert your atrial width from 9.6 to 10.1, and that changes the whole complexion. Now, Himangini, how do you define ventriculomegaly in the first trimester? Can we use the cutoff of 10 millimeter there?
No, definitely we cannot use a 10 millimeter cutoff in first trimester. So as we know, the famous butterfly sign in the first trimester, where choroid plexus fits snugly within the lateral ventricle. There is no CSF on the side of the choroid plexus or on posterior to the choroid plexus. Only anterior 1/3 or 1/4 is empty and it is devoid of choroid plexus. So when there is a lots of CSF, which we see as in this, around the choroid plexus, on the lateral side as well as the posteriorly, we can call it as a ventriculomegaly, or we can call this as a dangling choroid plexus within the ventricle. So in 2016, Gwendolyn and et al. Had described multiple ratios to describe it as a ventriculomegaly. So he described 3 ratios. That is the ratio of the choroid plexus length divided by ventricular length, choroid plexus diameter divided by ventricular diameter, and choroid plexus area divided by ventricular area. Among these 3 ratios, the diameter does not correspond very well with the further ventriculomegaly, while the ventricular length and the choroid plexus length and area ratio corresponds very well with, and which further goes into the second trimester ventriculomegaly. So as we see the choroid plexus, this is plotted against the biparietal diameter. So as we see that in the normal fetus without ventriculomegaly, these are the empty circles, the ratio is above 0.5, almost about 0.6. While in the ventriculomegaly feti, this is below the 0.5. So overall, we can say that when the ratio is less than 0.5, means the choroid plexus occupies less than half of the ventricle, we can call it as a ventriculomegaly.
Thank you very much. So basically, yeah, you have all these falling less than the 5th centile. So these charts are available in this paper by Gondolin, Marigold, Breaker et al. If anybody wants, they can look into it, and then you can fit into it. Now, Dr. Rahul Wani, what are the etiological factors of ventriculomegaly? So when you see ventriculomegaly, what all you need to think about?
When you see ventriculomegaly, basically what you think are 4 major areas. First thing is structural abnormalities, whether there are any CNS structural abnormalities or other structural abnormalities other than the CNS. Then you think about congenital anomalies like chromosomal anomalies, you think about infections, and you think about intracranial hemorrhage. Now, when you think about CNS structural anomalies, the most commonly which are seen as a Dandy-Walker syndrome, or the absence of agenesis of corpus callosum, Chiari-2 malformation, whether there is any aqueductal stenosis, or other any CNS anomalies like bifida, spina bifida, or something might also be associated with ventriculomegaly. The common infections which most commonly where you can see ventriculomegaly is toxoplasmosis, cytomegalovirus, and the parvovirus group. These infections you need to rule out. Trisomy 21 is one thing which is associated with the this ventriculomegaly, and there are a lot of syndromes which are associated with ventriculomegaly. I cannot enumerate all of these, and probably not everything is fit into this slide. There are many syndromes which are associated with the ventriculomegaly. So
I could just fit in only this much.
Major points of ventriculomegaly, I think I have enumerated.
Yeah, thank you, Rahul. And also Zika. I forgot,
Yeah,
I think Zika, okay, we say we don't have it here in India, but yes, it's that's not true. So Zika is one more thing that we need to take into, especially if they have a history of travel
And that's how the history of travel was taken
to the epidemic, Zika epidemic areas. Yeah, very good. Now, Sunita, now you've done a scan, you've seen ventriculomegaly. How do you extend your scan? like Rahul said, there are so many cranial abnormalities that can be associated. So what is actually a neurosonogram and what are the planes that you need to see?
Yeah. Good evening, everybody. So first we do a basic evaluation in the axial plane. The basic planes are the transthalamic plane, the transventricular axial plane, and the transcerebellar plane. So once we see ventriculomegaly on the transventricular plane, then we go on and do an extended neurosonogram. And extended neurosonogram is basically evaluation of the fetal brain. So it is similar to the neonatal neurosonogram, where we use the fontanelles and the sulci to image the brain. We do it as per the ISWOG guidelines, and neurosonogram is definitely indicated because it has a greater anatomical, it has a greater potential of diagnosing conditions, and also that it is a multiplanar imaging. So definitely we come to know much more information than we would get in the routine axial planes. So moving on, the approach to the fetal neurosonography would depend on the position of the fetus. If the fetus is in vertex presentation, then definitely a transvaginal neurosonography is indicated as compared to a transabdominal sonography. This is because a transvaginal sonography can show us the anatomical details in greater detail, especially the corpus callosum and the sulcations of the brain are also clearly seen on the transvaginal neurosonography. If the fetus is in breech presentation, we did not worry. We can still go ahead and do the transfundal, transabdominal evaluation, and that is also acceptable. Next, coming to the role of 3D in neurosonography. So definitely 3D has a definite role to play because so definitely 3D has a role to play, especially when you're not getting an appropriate window and the imaging is suboptimal, then you can use your axial planes to get coronal and sagittal sections. So moving back to the mid-sagittal section. So the mid-sagittal section is the hallmark, and it is one of the most important sections which we need to obtain in a fetal neurosonogram. In this plane, we can see the entire corpus callosum with all its components. We can see the cavum septum pellucidum. We can see the fourth ventricle, the brainstem, pons, and the vermis very clearly. If we include a color Doppler in this examination, we'll be able to see the pericallosal arteries and its branches. And this section alone will rule out many abnormalities for us and is to be definitely included in a neurosonogram. The parasagittal plane is also equally important because we can see the entire length of the lateral ventricle during this in this image, and we can also see the periventricular region and the cortex very clearly. Coming to the coronal views, we scan the fetus from anterior to posterior. In the anteriormost plane is the transfrontal plane, where we can see clearly the interhemispheric fissure. Moving on, we get the transcaudate plane, where we can see the cavum septum pellucidum between the frontal horns of the lateral ventricles. And the transthalamic plane shows the thalami on both sides of the midline. And the last plane which we get is the transoccipital plane, which we see through the posterior fontanelle. It shows the cerebellum and the vermis very clearly. So a fetal neurosonogram is not complete, or a CNS evaluation is not complete unless we do the complete evaluation of the spine. The basic evaluation of the spine starts with an axial sweep along the entire length of the spine. We should look for the 3 ossification centers and the central hypoechoic spinal cord. Moving on, we can do a sagittal section. The favorable position would be a prone position. Using the acoustic window provided by the unossified spinous process, we can see the spinal canal, the spinal cord, and the lower end of the spinal cord, the conus medullaris and the filum terminale very clearly. We also need to check for the intactness of the skin and the subcutaneous tissue to not miss out on the closed neural tube defects. A coronal scan may also be obtained if the position is favorable, or we can do a coronal scan using a 3D ultrasound from the basic axial sections.
Thank you.
This
Thank
would
you
be
for
a
that.
complete evaluation of the CNS.
Thank you for taking us through the complete, in a very, very nice way, and, taking us through the complete process of a neurosonogram. So, Dr. Priya Deshpande, when you're doing a neurosonogram, Sunita has told us this is the way we do it, but what all to see when you're doing a neurosonogram? Okay, these are the planes, you're getting the planes, but what all you should see in each plane, and which are the common CNS anomalies that need to be looked at,
Good evening, sir, and thanks for the opportunity here as a panelist. Well, it is very well explained in detail. How do we do a neurosonogram? It is basically looking at the brain at the finest details and looking for the structures which are formed normally, as well as to search for any abnormal findings, especially when we are seeing finding of ventriculomegaly, because ventriculomegaly is not a diagnosis in itself. So when it is found on scan, what we have to do is go further and look out for any other associated anomalies. Now let's categorize this into a few compartments. Since we are seeing dilatation of the ventricles that are the lateral ventricles here, we would want to have a look at the third and the fourth ventricles to see for any obstructive pathology causing ventriculomegaly. Then most important is the anterior complex, of which CSP is an important part which we see. And if it is absent, then it suggests that there might be abnormalities associated with the corpus callosum, a complete absence or a partial, complete agenesis or a partial agenesis. It can also be supplemented with the Doppler pericallosal artery. Then we have to look at the cerebral cortex. So cortical anomalies, especially with the sulcation and gyration, although we know that they are constantly evolving with gestation, and reduced sulcation may be seen in lissencephaly, which may be associated with ventriculomegaly, and even polymicrogyria where the gyrations are more. Then coming to the posterior fossa, where we have to look at the vermis. And why are we looking at each and every structure like that? Is to find out the etiology and the anomaly. So Vermian hypoplasia, Dandy-Walker malformations, or a megacisterna magna. Also have a look at the cerebellar hemispheres to look for hypoplasia. So all of this has to be looked for. And the pericerebral spaces, which are reduced in cases of obstructive hydrocephalus or ventriculomegaly. And in cases of cerebellar or cerebral atrophy, these spaces are increased. So these findings, these structures which we are seeing on a detailed neurosonogram will help us to find any etiology for our ventriculomegaly to come to a diagnosis of it being isolated or not.
This is a small checklist of mine, which
Yeah.
I use. It looks very exhaustive, but it is not. When you start using it, it becomes a part of your routine. Now, so the common anomalies which you need to rule out.
Yes. So these we've
Associated,
already.
because Rahul has also told us that we need to specifically look for certain things like agenesis of corpus callosum, Dandy-Walker, neural tube defects, aqueductal stenosis, tumors, migrational anomalies, all those things we need to look for. Thank you, Priya. Thank you very much for that. I'm not leaving you here because, see, Sunita has told us how to do it. You've done it according to the protocols. There is mild ventriculomegaly, 10.4, 10.4 on both the sides. You've done, you followed all the checklists. You have ruled out everything. There is no extracranial abnormality. Fetal echo is normal. Everything is normal. So at this moment, can you reassure the patient and tell them that, no, this is just an isolated mild ventriculomegaly and you don't need to worry about it? Because, we've all been reading that isolated mild ventriculomegaly has a good prognosis. So at this juncture, can you do that?
Well, yes, because isolated ventriculomegaly is a diagnosis of exclusion. And since we've seen everything in detail, intracranial as well as extracranial, and we assume we've also ruled out any other structural abnormalities. At this point, we would call it an apparently isolated ventriculomegaly. And while counseling, we would also we can reassure the woman according to the standard guidelines and the paper which is published in SFM regarding a 90% normal neurological outcome. So
at this
yes,
stage,
at this stage, although we know these are all developing and we would want a further assessment, and also we have to ask for a few investigations.
Why did you use the word apparently then?
Apparently, because we know brain is a constantly evolving structure, and there are around 16% chance of developing anomalies as gestation progresses. And even anomalies have been found later on, even at 1 year of age of birth. So at this time, we would want to do a few investigations, as I was talking about, like to rule out aneuploidies. We know it's a marker for aneuploidy. So amniocentesis with a microarray, and also evaluation for fetal infections, like we've been discussing, toxo, CMV, parvovirus, and Zika. So for that, we need to rule that out, and then we can be certainly sure, kind of reassured for the moment.
Yeah. Thank you, Priya. And so this is, I think she's used a wonderful word, that is, it is apparently isolated. So at this moment, we can reassure them to some extent, but then what she said is that we also need to tell them that there are certain other things we need to rule out, like infections, chromosomal abnormalities, and also we'll tell them the possibility of evolving anomalies that you have rightly pointed out. Now we move to Dr. Datar. See, Dr. Datar, Priya has said that yes, there is an association with chromosomal anomalies. So what is the association with ventriculomegaly, and should prenatal testing be offered to isolated mild ventriculomegaly? So these are two questions, sir.
Good evening, everyone. As we are aware that the possibility of a chromosomal aneuploidy, especially Down syndrome, is quite high whenever there's an isolated mild ventriculomegaly, because it acts as a soft marker for the chromosomal aneuploidies. So here, if it is an isolated mild ventriculomegaly, we are thinking more in the lines of a chromosomal abnormality. But the more anomalies that we detect, the possibility of it being non-chromosomal or a single gene cause is going to increase. So if we see a large series of these cases, about 3.8% of fetuses had an aneuploidy, and among that 2% cases had Down syndrome. So we know that the essentially for the likelihood ratio, if there's a mild isolated ventriculomegaly, is almost 25, which is quite high, and it's among the highest among the other soft markers that have been detected. So it acts as a good soft marker for Down syndrome. So always a screening by an invasive testing by FISH or QFPCR is always indicated in all cases of isolated mild ventriculomegaly. So you can see in this particular slide, that is the
that's the positive likelihood ratio. But as an isolated, if we want to calculate, it is 3.81. Yeah.
3.81. So it is relatively high as compared to all the other markers as well. So it acts as a very, very important screening tool for aneuploidy. So it's a good soft marker for aneuploidy.
So you mean to say that we need to rule out chromosomal abnormalities in every case?
Correct.
Right.
That's
now, correct. So okay. If it's a severe ventriculomegaly, this thing.
Correct. It shifts. So more and more anomalies that are detected. So we see agenesis of corpus callosum, or there could be certain structural malformations that are detected, or a possibility of sulcal or gyral abnormalities. Then it shifts more towards the single gene cause of this thing. So, or if it is more of an obstructive, then we know the L1 CAM mutations and the other causes will be very crucial there.
So now there is a battery of tests which are available: NIPT, FISH, conventional karyotype, microarray, whole exome sequencing, clinical exome. So which test, when, and why? On a practical point of view, because theoretically it's very easy to say, but so how do we go about it?
Now, typically, if you are taking the first test, NIPS is still be considered as a screening test, though it is a very good screening tool. It is a good screening tool for Down syndrome. For the other aneuploidies, the detection rate is not that quite that high, especially even for trisomy 18 and 13. But the test of choice here will be an invasive testing, wherein you would do a FISH for 5 probes and QFPCR as a first line testing. And if you find an abnormality, we know how to proceed. But if it is normal, then we usually would proceed with a chromosomal microarray, because a chromosomal microarray gives about 15 to 20% more information than a karyotype. So this is said and done in cases of a mild isolated type of a ventriculomegaly without any other major issues that have been detected on the scan. We go on deeper and deeper. So more the information that is available, the better. I give an example. I have 46 books on a bookshelf. That is the chromosome. So I'm looking at each book from outside and keeping it back. I'm looking at the karyotype. When I'm looking at each chapter or sub-chapter level, I'm doing a microarray. And when I'm going to the page level and reading it word by word, that is when I'm going for an NGS, next-gen sequencing test, or an exome-based study. So typically when we have only a mild ventriculomegaly which is there, we are looking more at the chromosomal level. So looking at the QF-PCR or a FISH for common aneuploidies, followed by a microarray would be a preferred modality. But if we are getting features like agenesis of corpus callosum or other structural abnormalities, we have to go to the gene-based level. Now, when we are talking about the clinical versus whole exome, as I mentioned in the slide, when we're doing a clinical exome, it is limited number of genes, say 8,000 genes which I'm reviewing. So which is 8,000 pages, I'm reading it word by word. Vis-a-vis the whole exome sequencing, I'm reviewing almost about 20,000 genes together. So here, when I'm evaluating for single gene abnormalities, I need to have more and more clues to reach a definitive diagnosis. So if I'm getting agenesis of corpus callosum with ventriculomegaly, I know which conditions to search for. The other factors that will be crucial is consanguinity in the family, previous obstetric history, which becomes very, very important. If there's consanguinity with a ventriculomegaly and an agenesis of corpus callosum, I know the problem is more at a single gene level, and wherein I would be more inclined to doing a clinical or a whole exome sequencing study. So
thank you. Yeah, so it's the thank you for bringing this up, because it's not just about ruling out trisomy 21. So NIPT, yes, if the patient is just not ready for this, I think NIPT would be an option there, but explaining to them what are the limitations that would come with NIPT also.
Absolutely.
Thank you, Dr. Datar. Thank you for that wonderful thing. Now, Dr. Rahul, how do you investigate the second reason, the second line of investigation which Priya has suggested is that we need to rule out fetal infection. So how do what all do we do for that, and how do you interpret a TORCH report?
Yeah, basically when we are thinking about infections, it is very unlikely that only an isolated mild ventriculomegaly will be seen. There could be associated other findings also. But if it is only mild ventriculomegaly and you want to investigate for infections, then you need to do an amniocentesis and do a DNA PCR for it, for the infections, or maternal serology for IgG, IgM of toxo, CMV, and parvovirus. If possible, Zika investigations we should do. Now, as far as interpretation of TORCH is concerned, now when only IgG is positive, we know the patient is immune, and we don't need to think about infections as a case. You can rule out infection as a cause of the, but when IgM and IgG both are positive, then you need to be very you need to know what was the timing of the infection, whether it is a recent infection or a chronic infection. So there the avidity test will help us. Now if the avidity test for IgG is low, then that means it is a recent infection and there is a possibility that there is a transmission from the mother to the fetus. But if the avidity test is high, that means this infection was a past infection and the possibility of transmission could be low. Now, we should also understand the limitations of this test. Now, if you're doing a PCR, DNA PCR on the amniote, when you do it before 20 weeks, the sensitivity is only 20%. But when you're doing it at a later stage, then the sensitivity improves to about 95 to 97%. So the limitations you need to know, and you need to interpret the TORCH investigations properly.
So it's not just about TORCH negative, TORCH positive. It's about looking at it in properly and then coming to a conclusion. Thank you. We'll have to quicken up the panel now, because we've covered up our time slot. So a few quick answers from everyone. Is MRI, Himangini, is MRI helpful? Should a MRI be offered to all the patients with ventriculomegaly? Dr. Himangini?
Yeah, so it is, we don't offer it to all the patients, but it is definitely complementary to the ultrasound. especially when we are looking for a sulci and gyral abnormalities. Certain times on ultrasound it is not seen, or if the fetus is in the breech presentation, we cannot even do the transvaginal scanning. So at that time, the MRI is helpful. Usually it is done between 26 to 28 weeks. And especially it is helpful in the neurodevelopmental anomalies as well as in the migrational anomalies, gyral anomalies.
The message here is that it also depends upon what is the expertise of the person who's, there are studies which have said that, you can have, 16 to 25% additional findings than ultrasound. But then we don't know what was the level of the ultrasound person and what was the level of the MRI person. So, and secondly, embryology is not going to change, is not going to become faster for an MRI. So if there are certain things because of embryology, you're not going to see on ultrasound, so don't use MRI as a batting tool. That because you just want to push this patient to from a ultrasound to an MRI, so that because the patient is paying 10,000 there, so hereafter the headache is going to be the MR guy, is not mine. So don't do that. MRI has its role, but we need to use it meticulously in cases where we really require them. Now, Sunita, what about unilateral ventriculomegaly? Is it common? How should it be managed?
Yes. So initially, most of the studies, they concentrated only on the bilateral ventriculomegaly. So some of the recent studies which have come out about unilateral ventriculomegaly, they say that the incidence of unilateral ventriculomegaly is almost as high as 50 to 60%, which is much higher than what was reported earlier. So the causes of unilateral ventriculomegaly may be infections, hemorrhage, or partial agenesis of corpus callosum. So what we want to say is that unilateral ventriculomegaly is not very rare condition. It is fairly common, and we need to deal with it in a manner which is similar to the bilateral ventriculomegaly, because the risk of neurodevelopmental delay in a case of unilateral ventriculomegaly is around 6 to 7%. And this is almost the same as in the case of a bilateral ventriculomegaly. Also, generally in the association of structural abnormalities is more in the case of a bilateral ventriculomegaly than isolated unilateral ventriculomegaly. So we need actually more data and larger studies to come to a conclusion. Until then, we can go on and treat unilateral ventriculomegaly just as we treat bilateral ventriculomegaly.
Yeah, Dr. Datar, this study, this meta-analysis, in fact, they found out that unilateral had a 0% association with chromosomal abnormality, and congenital infection was 8%, neurodevelopmental delay 6 to 7%, which would be seen otherwise also in a normal that is in the population. So then, do we not need to do any chromosomal evaluation for unilateral ventriculomegaly? Or this is not sufficient, we need to wait for some time before we jump into it?
Changing a little bit, wherein unilateral ventriculomegaly, again, that word apparent is very crucial. We recently had a case wherein there was a unilateral ventriculomegaly with a hypoplastic nasal bone. The invasive testing was declined and child ended up with Down syndrome. So nowadays, these outcomes are going to be very crucial. So that apparent word is going to be important. And secondly, the role of MRI also becomes very important in cases of a unilateral ventriculomegaly. So we should treat these unilateral ventriculomegalies on the lines of the bilateral ventriculomegalies.
Okay. So, and Himangini, what is asymmetric ventriculomegaly and what is its significance?
Yeah, so asymmetric ventriculomegaly means the difference between the two ventricle sizes 2 millimeter or more. We call it as a asymmetric ventriculomegaly. And it is studied that asymmetric ventriculomegaly is usually more associated with neurodevelopmental delay more than the symmetric ventriculomegaly. Even the etiologies of asymmetric ventriculomegaly is slightly different. In the torch infections, as well as in the hemorrhage or in the periventricular leukomalacia, which occurs antenatally, we get usually a asymmetric ventriculomegaly. While in the chromosomal anomaly, corpus callosal agenesis, we usually get a symmetric ventriculomegaly.
Okay, thank you very much. Now, Sunita, now
Yes.
we get into the rapid fire mode now, because we've already overshot before the organizers just tell us to stop.
Yes. Yes.
Let's do it. 19-20 weeks, mild ventriculomegaly, all whatever has been told that it was apparent initially. So infection screen was done, CMA was normal, everything. So how will you counsel this patient? Now, can you reassure them?
Yeah. So we'll reassure the patient, so far so good, but we need to wait and watch. So we explain very clearly that the prognosis depends on two major conditions: whether there is progression of the ventriculomegaly, or if any associated abnormalities develop later in the gestation, which were not seen in the previous scans. So the natural history of ventriculomegaly is that the larger percentage of the cases remain stable or regress. Only 16% of the cases go towards progression, and these are the cases which are at risk for neurodevelopmental delay. Also, we need to tell the patient that in spite of best of efforts, in spite of doing a thorough anomaly scan, a full diagnostic workup, plus a follow-up scan in the third trimester, and maybe even a fetal MRI, there will be around 7 to 10% of the fetuses with mild isolated ventriculomegaly, which on postnatal examination will reveal additional structural abnormalities.
Thank you.
So we need to counsel the patient accordingly. Yeah.
So we coming to the end of 3-4 rapid fire questions. Priya, how is the outcome of isolated mild ventriculomegaly? How would you counsel this patient? Isolated, because we have done everything now. Yeah.
Yes, so we've done everything. We've now come to a conclusion of isolated, and we would like to give hope to the couple, saying that, telling them that the survival and a good neurodevelopmental outcome chances are 90%, and the chances of neurodevelopmental delay are 10%, which are almost equal to that found in the normal population in otherwise fetuses or babies who will be born without any other problems also. So it kind of equates, so it is not a dismal prognosis. You have to give them a good picture.
Thank you. Very important message here. So mild ventriculomegaly, yes, we need to do everything possible, but mild ventriculomegaly, just going for termination is not the answer. 90% of them will have normal neurodevelopmental outcome if you have ruled out everything. So that is a very important message that we are trying to give through this panel. And how is the outcome with moderate ventriculomegaly between 12 and 15, Sunita?
So the cases of isolated moderate ventriculomegaly, where the ventricular diameter is between 13 to 15 mm, the women should be counseled that the outcome is likely to be favorable. That is, the survival rate is good, 80 to 97%. But the adverse risk of a mild neurodevelopmental delay, that outcome has to be explained. The risk is slightly higher than that with the mild ventriculomegaly in cases with moderate ventriculomegaly. And the likelihood of normal neurodevelopmental outcome in these patients is about 75 to 93%. So the risk is slightly higher than cases of mild ventriculomegaly.
And what about severe, Dr. Dattar?
Severe ventriculomegaly, the outcomes are generally informed to be guarded, but the exact outcomes, we know that survival is possible in about 80%, but they will have certain delays. Neurodevelopment, about 40% of them may achieve, but that's very crucial as to how the further workup is considered. And typically what we need to consider whenever these cases, children are born, we need to evaluate for any other associated causes and always store the DNA, because we know that in cases when there's fatality, we should have some DNA sample with us to work up further for specific causes or genetic causes which may be responsible. So sometimes it could be an asphyxia related event, but it turns out to be that it was a fetal MTHFR deficiency which had led to the ventriculomegaly. So very crucial to have a proper diagnosis in these cases wherever the fatality is expected, but otherwise a proper neurodevelopmental follow-up is what is required.
Thank you very much. Dr. Rahul, does the diagnosis of ventriculomegaly alter the timing and mode of delivery?
No. Timing and mode of delivery is only as per the obstetric indications, unless there is progression of ventriculomegaly and you are planning a shunt from the then to survive to cortex to prevent further cortical damage. You might deliver the patient early. Otherwise, it is as per the obstetric indications.
Thank you. Now, last question, Priya. We've talked about 10 millimeter. If the atrial width is 9.7 millimeter, what will be your approach?
Well, this is mathematics and biology. But since 9.7 is very close to 10, we would be vigilant in such cases, but not panic at the same time. and preferably call them for a follow-up after 2 weeks. And keep in mind all the other, the neurosonogram and everything which we've done. And if we follow up after 2 weeks and we find progression, then we have to follow the guidelines which we've been talking about to do further investigation. But we won't alarm them at this point and just keep it.
Yeah, we'll just inform them that this is on the higher side of normal. We would like to follow this up, because 10 millimeter that we say is actually +4 standard deviation. 10 millimeter is +4 standard deviation. Okay, so how do we handle it? Diagnose ventriculomegaly, grade them, detail scan, apparent ventriculomegaly, counsel, do take genetic consultation, get genetic evaluation, infection screen, MRI, query, counsel them again, do serial evaluation and counsel them again. So the issue is, the major issue is that the problem is, we don't have enough time. We diagnose it at 19 weeks. We don't have enough time to do all these investigations. But fortunately, the law is changing now. And, we can, with the court's permission, still go ahead and the patient can get things terminated if things turn out to be the worst thing. And the take-home message is 10 to 12, 12 to 15, and greater than 15 is what we need to use. And ventriculomegaly, as Himangi said, is just a finding, not a diagnosis. Isolated ventriculomegaly is a diagnosis of exclusion. And before you say it is isolated, and before you, counsel the patient and try to reassure them, do the best possible to make sure that it is isolated before you say so. Thank you very much. Thanks everyone for a wonderful, taking us through all these aspects from the practical point of view. My sincere apologies to the organizers for overshooting, but the topic itself is something which is very difficult to squeeze in into 25 to 30 minutes. Over to you, Mohit.
Oh, it was a wonderful panel. Every minute of it, there's comprehensively covered every aspect of ventriculomegaly. So I'm sure no one is complaining. We have 400 still logged on. So you could have still gone on for 5 minutes. It wouldn't have mattered.
We need the 5 questions we need 5 minutes for the questions. There are some unanswered questions.
I would leave it to Khurana, sir, but at the same time, there are a lot of questions for this pen. I would request all the panelists to hang on and answer them in the chat box, please.
Yeah, we'll do that.
Any question unanswered, let Khurana, sir, take the first 5 questions, and please, the rest of the questions can be answered by the panelists. Thank you so much. Over to you, sir.
Thank you. So, very short answers, really. One is asymmetric but normal sized ventricles. Any importance?
Anyone can take it. You can take it, or Priya, whoever.
Yeah. So asymmetric definitely gives us a little, we should be a little vigilant, and probably follow-up would do after 2 to 3 weeks minimum interval.
Yeah.
And it is associated more with neurodevelopmental delay as compared to asymmetric.
But asymmetric with normal size ventricles.
Yeah, of course, if it's dilated, then it's a different policy. Then we follow just like for ventriculomegaly, but otherwise a 2-week follow-up, just to make sure that it's not the beginning of a unilateral process. Then there was also this business of obstructive versus non-obstructive. Can we differentiate that on an ultrasound?
Yes, of course we can. Especially when we are seeing a third and fourth ventricle dilated along with the lateral ventricles, and we see aqueductal stenosis or obstruction there. So these are the pointers towards obstructive. And also we'll see the pressure changes and the BPD changes, and pericerebral spaces will be less. So that gives a pointer toward the etiology of it.
Yes, but they're not very specific, and we still cannot swear that, yes, it would not be non-obstructive. So we keep a relatively open mind that, yes, possibly, but not always. And then there's a question on non-progressive ventriculomegaly. Does it have a better prognosis compared to progressive ventriculomegaly?
Yeah, definitely. The non-progressive ones, as I have said, if the ventriculomegaly remains stable or regresses, then definitely the risk of neurodevelopmental delay is much less in those cases, and the prognosis will be better as compared to cases which progress.
Yes.
Non-progressive ventriculomegaly is a good sign, and we should consult the patient.
Yes, I mean, also need some clarity on the time of MRI. I thought Bimal made it clear, but someone still thinks that 18 weeks is better than 26 weeks. Bimal, would you please tell us loud and clear?
No. See, that's what I'm saying. 18, 19 weeks MRI is basically just for getting another investigation done. If you've done a 19 weeks, you've done a good neurosonogram, I don't think MRI is going to add anything. It also, that's what I said, it all depends how confident you are about your ultrasound. If you are really not, maybe MRI would push in. But finally, all this sulcation and gyration, if you can't see it on ultrasound at 19 weeks, how is MRI going to do it? It's not going to hasten the embryology, actually.
True. Thanks so much. The wonderful panel, I must say. And before we move on to our next panel, if we can have a tiny...
All right, then. We move on to the next case of the right side aortic arch. And to moderate this session, we have Dr. TLN Praveen sir. He is the president of the Society of Fetal Medicine. He has a huge biodata, which I think it's futile to read out now. But he's going to introduce the speaker and the panelists for his panel discussion. And I hand it over to him, sir. So over to you, sir.
Thank you, Mohit. It was a wonderfully planned program. And I really would like to congratulate you and all your associates who are responsible for this Navi Mumbai SFM program. And I would really, I'll be failing in my duty if I don't congratulate Ashok for giving a wonderful, wonderful lecture on NT in 2020. It sounds very rhythmic and very interesting. And he made it really interesting. Now, I think if we leave Bimal, I think he will take us through the whole night with ventriculomegaly. So anyway, we were fortunate that we have been given this opportunity. Anyway, I would like to introduce my panel. First and foremost thing, we have a very young, dynamic Ashok Lalji, who is the speaker, or who is the presenter, who is going to present this case of right aortic arch. And he has been working in Vashi for the past 15 years, and he is a radiologist. He has contributed a lot of papers which are peer-reviewed. Not only that, he has co-authored a book on ultrasound, abdominal ultrasound with one of the greatest, that is Dr. Anil Ahuja. Then we have our panelists who are really brilliant, and I'm sure that they will take us through the right aortic arch in a very methodical way and give us a clear idea about what to look for and how to look for and what are the changes that we have to expect from these things. And for that, we have Dr. Alpana Joshi. Alpana Joshi needs no introduction to all of us because she has been with us for the past 23 years. She has been practicing radiology. She's a gold medalist in MD radiology, and she was associate professor at Nair Hospital. And not only that, she has been the director of Shobha Diagnostics. Then we have Chetan Singhal. He's actually a alumni of Scholar MD, and he is a radiologist who has been the director of this, what is it, scan center name is that Krishna Diagnostic. And at the same time, he has been instrumental in organizing the whole panel for us. And then we have Anu Vij. Anu Vij is a senior gynecologist obstetrician who has been a consultant and of various hospitals. And she's a consultant for Motherhood Hospital as well as the Apollo Hospital, director of Anurag Nursing Home. She was past president of Navi Mumbai Obstetric and Gynecology Society. Then we have Shagun Agarwal. Shagun Agarwal is from my town, that is Hyderabad. She's a very, very excellent geneticist, and she has been the additional professor of medical genetics in Nizams, as well as a scientist in charge in CDFD. And she has innumerable publications to her credit, and she has done a lot of innovative original work. Then we have Pooja Vazirani. She is a consultant fetal medicine specialist, and she has been basically a gynecologist obstetrician, but got trained, had a 2-year fellowship from Mediscan, and she has been the consultant at Hiranandani as well as Surya Mother and Child Hospital and Grace Maternity. So these are my wonderful panelists who are going to take us through the various aspects of right aortic arch. Now I request Dr. Slok to present his cases. Can you share your
yes.
presentation?
Sir, is my screen seen?
One second.
Yes, very well.
Yeah,
Your voice is also perfect.
yeah. Thank you very much.
The audio is perfect.
Thank you, sir, for the kind introduction, and good evening, everyone. At the outset, I would like to thank Khurana sir, Dr. T.L.N. Praveen sir, Dr. Bimal Sahni sir, and Dr. Mohit Shah to giving us this opportunity to organize this event at the prestigious SFM platform. I thank all the esteemed panelists as well as the delegates. Today, I'm going to talk about the aortic arch abnormalities. Aortic arch abnormality can be an isolated finding or could be part of complex cardiac malformations. The first case is of a 25-year-old lady, gravida 2, living 1, in a non-consanguineous marriage. Dating scan was done at around 9 weeks. First trimester screening done elsewhere was at 12 weeks, 3 days with NT of 1.2 millimeters. No other markers were found. Combined risk for trisomy 21 was calculated to be 1:2,700. This is the normal 4-chamber view of the heart with levocardia. Normal atrioventricular concordance is seen. This is the standard left ventricular outflow tract where the normal aortic root is seen with an antegrade flow into the aorta. This is the color sweep of the heart for a sequential segmental analysis where we can see the crossing over of the great arteries and normal ventricular arterial concordance. This is the 3-vessel view. From left to right, what we see is the normal size pulmonary artery dividing into the right and the left branches. Aorta is in the center and SVC to the right. This is a 3-vessel trachea view, the most crucial view. What we see here is a beautiful U-shaped configuration of a right aortic arch. So in this, the transverse aortic arch is seen to the right of the trachea. Trachea is seen as a rounded structure, and the ductal arch is on the left side, and they both join behind the trachea to form this classical U-shaped structure or a loose vascular ring. A cine loop again. This is a still image where the ductal arch is seen. The trachea is seen as an echogenic ring, and the right-sided aortic arch. A section higher up, we could see the left subclavian artery arising from the junction of ductal arch with the descending thoracic aorta from the region known as Comeral's diverticulum. The course of the left subclavian artery is aberrant as it could be seen coursing behind the trachea and reaching the left shoulder. This is the ALSA, and it is often associated with the right ductal arch, right aortic arch, left ductal arch abnormality. As we go higher up in the superior mediastinum, we can see a normal echogenic thymus behind the sternum. To summarize our finding, basically we found an isolated right aortic arch with a left ductal arch, a normal appearing thymus. No other intracardiac or extracardiac anomalies were found. The patient was counseled about the possibility of an underlying chromosomal abnormality. However, the couple didn't undergo any further invasive testing and continued the pregnancy. A normal postnatal follow-up was obtained at 1 year. The second case has been shared by Dr. Bimal Sahni, sir. Thank you very much, sir, for the case. She was a 27-year-old primey in a non-consanguineous marriage. A dating scan was done at around 10 weeks. No first trimester screening or an NT scan was done in her case. She came for an anomaly scan, and this is the cine loop. This is a 4-chamber view of the heart. There is left axis deviation of the heart. As we could see, there is a malaligned VSD with a dilated overriding aorta. And if we see in the posterior mediastinum, we can see the descending thoracic aorta to the right of the spine. These are the still images where the overriding aorta with the malaligned VSD is seen. This is the classical Y appearance on color imaging with the VSD and the overriding aorta. This is another cine loop where we could see the overriding aorta. And as we go higher up, the RVOT, that is a pulmonary artery, is narrow in caliber. Thus, we concluded it to be a tetralogy of Fallows. This is again showing a narrow pulmonary artery and a dilated overriding aorta. However, as we go higher up in the three-vessel trachea view, we see the transverse aortic arch to the right of the trachea and the ductal arch on the left side. However, they are forming a U shape, but the ductal arch is narrow in caliber because of the underlying pulmonary artery stenosis. In the superior mediastinum, we could see the left brachiocephalic vein almost touching the thymus. Thus, we were suspicious about absent thymus or thymic hypoplasia. To summarize our finding, a tetralogy of Fallow with pulmonary stenosis and right aortic arch, hypoplasia of thymus, no other extracardiac abnormalities seen. Couple was duly counseled about the high risk for the underlying aneuploidies. Amniocentesis was done and FISH revealed a 22q microdeletion. And thus the couple opted for termination of pregnancy. Thank you very much, sir.
Thank you, Dr. Alok. Shlok, it was wonderful and wonderful images, and I really thank Vimal also to have supported you with the second case of with tetralogy of Fallows. Now, yeah, I will share my screen and we will take over through the various aspects of the sorry. Okay. Good evening, everybody. Now we will take over and go through the various aspects of right aortic arch. Now, first and foremost thing, when we talk about the right aortic arch, it is extremely essential that we need to understand the basic embryology of how these aortic arch develops. Because unless you understand the embryology of aortic arch or the development of the aortic arch, it becomes very, very difficult to understand the various variations and combinations of right aortic arch abnormalities. With this background, I have already introduced my panelists. So I'll straight away take over to the two cases that have been presented and give you a brief introduction saying that the aortic arch, today the aortic arch abnormalities, which are now we are going to deal with the things which are concerned with the course and its branching pattern. And they are the right aortic arch with left ductus, that is, it gives you a U sign with aberrant left subclavian or innominate artery. Whereas sometimes you have a variation which is called as the right aortic arch with right ductus, where we have a V sign, where there will be a mirror image branching of the right aortic arch. And then we have the double aortic arch with the lambda sign. Another one is that the left aortic arch, which is normal, with an aberrant right subclavian artery. But then today we are not going to deal with this. We are going to deal with these three conditions, which are most important things which we come across. And as such, if you take these aortic arch abnormalities, they are very rare. They are not very common. And they're usually associated with conotruncal abnormality. This is one thing which we have to keep in mind, because when you do a three-vessel trachea view and when you find that there is either a V or a U, then in that situation, you have to immediately look for the conotruncal abnormalities. And not only that, whenever you have this sort of a situation, we have to need to think in terms of the chromosomal abnormalities, particularly in the form of 22q11 or a trisomy 21. Not only that, the importance of diagnosing them prenatally is that these are the fetuses which in the neonatal period, they can present with the compression of the trachea as well as the esophagus. Particularly when we have an aberrant left subclavian artery, there can be what is called as the left subclavian steal due to constriction of the aberrant artery. And most often these abnormalities are picked up in the three-vessel trachea view And one of the commonest the common feature is that you find that the aortic arch is on the right side. With this brief introduction, I will let my panelists talk about various aspects of it. As I said, it is extremely important to understand the basic embryology. I would like to ask Dr. Chetan to give us what is the theory that is followed in understanding the embryological development of aortic arch.
Good evening, sir. Thank you for the brief introduction. Before we go to abnormalities of the aortic arch, it's very important to understand the normal embryological model. This was proposed by Edwards in 1948, a double aortic arch model, where there is aortic arch on the right side, the other aortic arch on the left side. Both are aortic arch, they join posteriorly to form the descending aorta. Each arch gives rise to a common carotid artery and the subclavian artery respectively. And the pulmonary artery is the right pulmonary artery as well as the left pulmonary artery. They join the respective arches through the ductus, which is the right ductus and the left ductus. So once we understand the basic model, it is easier to understand all the abnormalities of the aortic arch, because all the abnormalities are basically a result of a persistence or the regression of particular segments. So it's important to understand this basic model. I hand it over for the next embryological part.
Thank you very much, Chetan, for that brief, wonderful description and clearly delineating by the diagram which is adjacent to it. And now we will ask Shlok to tell us about the embryological development of normal left-sided aortic arch, which is absolutely normal for us.
Basically the right aortic arch beyond the point of origin of the right subclavian artery undergoes a regression. The right ductal arch also regresses. Left ductal arch and left aortic arch persists and forms a V-shaped configuration to the left of the trachea, which is what we see in the 3-vessel trachea view. The first vessel to arise is the right innominate, which is actually formed because of the merger of right subclavian and right common carotid artery. The second vessel to arise is the left common carotid artery, and the third last branch to arise is the left subclavian artery. This is the normal embryological origin.
Very nice. Thank you. Thank you. So now we have understood how the arches develop. The second most important thing is now we know how a left-sided aortic arch, which is normal aortic arch, which normally develops by the regression of the right ductal arch as well as the right side of the aortic arch. Now, Pooja Wazirani, can you please explain us the embryological events in the right side aortic arch with right ductus arteriosus and with mirror image branching of the brachiocephalic arteries, V sign, that is V sign.
Thank you, sir. So basically what Dr. Shlok explained, this will be a classic mirror imaging of the embryology as well. So there's a regression of the area beyond distal to the left subclavian artery. Along with that, the left ductus also regresses. And then there is the unition of the left common carotid and the subclavian artery to form the common right-sided brachiocephalic. Then you have the right common carotid, and then you have the right subclavian. So it's an exact mirror imaging of the left aortic arch and forms on ultrasound the V on the right side of the trachea rather than the left side.
Thank you. Thank you very much. Now I would like to request Alpana to take us through the events of U-shape, U sign, that is the right aortic arch with left ductus arteriosus. Dr. Alpana.
Good evening, everybody. This is the most common form which we see, in fact, the U, a kind of the vascular ring. So here what is happening is the left aortic arch regresses, but it regresses between the left common carotid and the left subclavian. So that's why you get that U kind of a configuration, and the left ductus persists in the region of left subclavian artery and the right ductus will regress. So now there is a U-shaped vascular ring which is formed by the right-sided aorta, trachea in the center on the right side and the left ductus on the left side. So now the vessels which are going to originate from the aorta are from the order from right to left. Is first is the left common carotid artery, then is the right common carotid, and then there is right subclavian. And the left subclavian is going to be the aberrant artery. So it is going to be the aberrant left subclavian artery in this cases. And sometimes that left subclavian can arise directly from the glomerulus diverticulum. So that will be the embryological origin for the U kind of the vascular ring.
Right. Thank you, Alpana. And now let us try and see with Dr. Pooja. Can you please explain us about the double aortic arch, embryological events of double aortic?
So the embryological events in the double aortic arch is persistence of the embryonic structure. Like as Chetan explained in the first embryology by Edwards, we have a double aortic arch theory, and if this persists, then you have a double aortic arch, that is the right side aortic arch along with the left sided, which unite behind the esophagus and trachea, actually forming a tight vascular ring or the complete ring. Now the right sided aortic arch gives rise to the right sided vessels, that is the right common carotid followed by the right subclavian, and the left sided has the corresponding vessels, that is the left common carotid followed by the left subclavian. So these are these tight vascular rings which usually require intervention postnatally. And on ultrasound, you will be seeing the left ductus. In most of the cases, you will have the left ductus which is persistent and the right regresses, and the aorta giving rise to the left aortic arch and the right aortic arch and a complete vascular ring around the esophagus and trachea.
Thank you very much. Now, can you, Dr. Alpana, can you explain the grayscale as well as the color? Now we have understood the embryology, the events that they take place, the course of the aortic arch, the various branches, how they are going to form. Based on that, now let us translate it into ultrasound image. So can you please enumerate us and explain us the grayscale as well as the color Doppler features of right-sided aortic arch with persistent right ductus?
So a 4-chamber view will be normal unless you really look at that area behind the heart, and where you will see the aorta. Instead of it being on the left side, it will be just kind of anterior to the spine. So that should catch your eye, and you should then keep that in mind and be more vigilant. And of course, the 3-vessel trachea view, you will get the diagnosis. The aorta is on the right side to the trachea instead of left of the trachea, and it forms a mirror image, so a V sign. And that's how that normal configuration of the 3-vessel view is lost, and you get the V formation to the right of the trachea. So aorta and the pulmonary artery, they merge to the right, and normally you see it on the left side. So sometimes it may be difficult to demonstrate a right ductus, and let's say the pulmonary artery will be behind the right-sided aorta, and then it might be a little difficult. So left common carotid and left subclavian merge and form the first branch, and that is the mirror image, then the normal. And the second branch is the right common carotid and third. These branches may not be really seen very well on ultrasound unless you really make efforts for this. But in a 3-vessel view, that typical V configuration will definitely catch your eye. And of course, the color Doppler also will show you the same finding.
Thank you, Dr. Alpana. So this is how you have to. So the first and foremost thing that triggers your attention is the presence of the descending aorta either anterior to the spine or to the right of the spine. Then you look for the 3-vessel trachea view, and then once you find this 3-vessel trachea view onto the right side of the trachea instead of the left side of the trachea, that augurs us to look for other congenital heart defects, which we have to further evaluate, and also color Doppler confirms the findings. Now, Dr. Pooja, can you please explain us the color grayscale as well as the Doppler findings of right-sided aortic arch with the persistent left ductus?
So as Sir has specified that whenever you start imaging the heart, we have to have a sequential approach. So 4-chamber will clinch or make an effort to see the aortic arch properly, that you will have a descending aorta just anterior to the spine or to the right. And then the most important view to diagnose these arch abnormalities is the 3-vessel trachea view, whereby you will be having the right aortic arch, that is the aortic arch to the right of the trachea. You will have the left ductus, which is persistent, and in between them, you will have the ecogenic ring of the trachea. These two will be joining behind them, forming the U-shaped structure, that is the partial vascular ring, which is also loose, and therefore it is known as the loose vascular ring. This is the grayscale imaging of the U-shaped structure, that is the right aortic arch along with the left ductus. But however, to lay importance, whenever you have arch abnormalities, especially the right-sided aortic arch, you also need to view 2 things. You will have the aberrant left subclavian artery in this, because the ductus is on the left side and the aortic arch is on the right side. This is very well demonstrated when you go a bit up more than the 3-vessel trachea view, and then have a low pulse repetition frequency to see the aberrant left subclavian artery. The third important thing in this view, whenever you have arch abnormalities, is visualization of the thymus. That is because thymic abnormalities are associated with conotruncal abnormalities and arch abnormalities. So two pioneering efforts by Professor Palladini and Professor Rabi, that is the thymic box, which is important. When you have a perfect incination in the axial view of the mediastinum, and if you're visualizing the 3-vessel view or the 3-vessel trachea view, you'll see a less echogenic structure than the lungs. If the angle of incination is excellent, then you get a clear demarcation between the thymus and the lungs. It's roughly oval. And the second effort is objectively measuring, that is the thymic ratio to the thoracic ratio, which is done by measuring the posteriorly to the sternum to the posterior part of the transverse aortic arch, and at the same midline line, just extend the line to the thoracic vertebral area anterior. So the ratio which is seen till the late trimester, that is, it's irrespective of the gestational age, is 0.44. However, with arch abnormalities or conotruncal abnormalities especially, we would have a lesser ratio, that is 0.3 to 0.25, and a very important part in diagnosing arch abnormalities with thymic aplasia or hypoplasia, as the second case of Dr. Shlok is showing a classic hypoplasia of the thymus.
They are also associated with sometimes with trisomy 21, 18, as well as fetal growth restriction, particularly the thymic hypoplasia. And the color Doppler will definitely help us to identify the location of the 3-vessel and the distance between the sternum as well as the greater vessel, because you can find that the great vessels are very, very close to the sternum. Thank you very much, Pooja. And now we move on to the other thing, that is the double aortic arch, and let us ask Dr. Chetan to help us in identifying the features of grayscale features as well as color Doppler features of double aortic arch.
So as has been already explained, double aortic arch is nothing but an extension of the normal embryologic model, where we have the right aortic arch on the right side, the left aortic arch on the left side. They join posteriorly to form the descending aorta, thereby forming a tight vascular ring, encasing the trachea and the esophagus in the center. So the only thing that disappears is the right ductus. Normally the left ductus is persistent. The left ductus joins the descending aorta, forming the classical lambda sign. Sometimes a double aortic arch may be misdiagnosed because the left aortic arch may be atretic or hypoplastic. In those cases, we may miss a diagnosis of a double aortic arch. However, this lambda sign is a classical sign where we see the aortic arch on each side and forming a complete tight vascular ring.
Yeah, thank you. And then this is also what you call it as a reverse N sign. That is one more thing that will really help us, where you can see the arches on either side, and the central echogenic trachea will help us in identifying this double aortic arch. Now, let us get on to Anuj, the obstetrician with us, who is going to take our cells. So, madam, the patient has been sent with an ultrasound report of right-sided aortic arch. And as a clinician, what are all the things that you want to know about?
Thank you, sir. When I see a report of right-sided aortic arch, the first thing which comes to mind is that what all associated anomalies are seen along with this report, whether this is an isolated anomaly or whether there are cardiac and extracardiac anomalies along with this report. So I would try to look for that in the report, and if I have not found, I would again like to send the patient to the clinician and specifically ask about these findings. Plus, if I can get hold of the patient's anti-scan, I would again go back retrospectively to see what is the nuchal thickness in that scan. And like these days, we are doing the 4-chamber view and 3-vessel view as early as 11 weeks. So I would like to go back and review those images to see whether it was seen there or it was missed somehow. Plus, I would be more keen on seeing what the HbA1c levels of the patients are when she had conceived. At the time of conception, what are the periconception glycosylated hemoglobin levels? Because they really have a bearing on the cardiac problems. That's how I would like to go about.
Yeah, Thank you very much. And Chetan, how are Dr. Anuvaj has asked you to look at the NT, and how early can you make out the right-sided aortic arch? And has 3D any bearing on giving us additional information as far as the right-sided aortic arch is concerned?
So right aortic arch can definitely be diagnosed in a first trimester scan, NT scan. We normally take a color image of the 4 chambers as well as the outflow tracts. So once we see a U sign on the outflow tracts, it would give us idea that there is a possibility of right aortic arch. 3D with a TUI will definitely help because we can get coronal images wherein we can see the laterality of the aortic arch in relation to the trachea, and also the branches that come out from the aorta. That will help us in finding out the variant of the right aortic arch abnormality.
Yeah, and not only that, because you are taking them at various planes, you can even evaluate the various branches that are coming out at various sections. So that will also be of help in as far as TUI is concerned. Now, Alpana, what are all the cardiac and extracardiac abnormalities that you expect with the right aortic arch?
As we saw with that previous case also, we know that the conotruncal anomalies are most commonly associated with these. So something like TOF, PAVSD, CAT, then even absent pulmonary valve syndrome, tricuspid atresia, DORVs, and things like that. And one should remember that they are associated with then this 22q11 microdeletion. So that is to be borne in mind. And the extracardiac anomalies are also found in quite a number of patients, as you can see here, around 31.6% cases they're seen. So chromosomal anomalies, extracardiac anomalies, in chromosomal especially 22q11 should be kept in mind. And with right-sided arch and plus the cardiac abnormality, the incidence of extracardiac and chromosomal abnormalities are also common compared with the right aortic arch with the normal structural heart. So that should be kept in mind, and you should look for these anomalies specifically.
Thank you. Thank you very much. Now, I think we will go and ask our medical geneticist, Dr. Shagun, to help us in evaluating this right aortic arch, and how are we going to go about evaluating for 22q micro 11 microdeletion as well as T21. What is your advice, and can you please enumerate us regarding the 22q 11 microdeletion?
Good evening, everyone. There have been actually many large studies, and in fact 2 very large meta-analysis as late as 2016 and the very recent one in 2020 itself, which actually has studied at least more than 500 babies with a right aortic arch. Data from all this literature basically shows that around 9 to 15% of fetuses with a right aortic arch would be having an underlying genetic abnormalities. So the most common one, as we have already seen, is trisomy 21, or it could be 22q11 deletion, which is also called as Digeorge syndrome. But besides that, various other rare genetic conditions, including a chromosomal disorder called as Pelister-Killian syndrome, and some other rarer microdeletion syndromes, are also reported to be associated with right aortic arch. So how do we so usually, like whenever you have a fetus whereby you have a cardiac abnormality associated, like we saw in the second case presented by Dr. Shlok. So in such a case, the possibility of an underlying genetic disorder would be on an average around 25%. And in cases where there is no cardiac defect, then this is something which is also sometimes referred to in literature as an isolated right aortic arch. But these cases again could have an extra cardiac abnormality. So if overall we see if there is no cardiac defect with or without an extra cardiac abnormality, then still we have around 7.5 to 9% of the fetuses having a chromosomal abnormality, which gets picked up on a basic karyotype. And on an average, around 5% of these fetuses would still have a 22q deletion. So there is no cardiac defect. It's only an isolated right aortic arch, but there could be an extracardiac abnormality, or may not even be there. Your isolated right aortic arch may be your only finding. So then also around 5% could have a 22q deletion. And if we try to further dissect this and just, sir, we'll go to the next slide. Yeah, if there is no extracardiac abnormality, then the percentages kind of become a half, but then this is still significant. So around, you can say around 5% to 10% of these fetuses with nothing, with only an isolated right aortic arch, no cardiac, no extracardiac abnormality, could still have a karyotypic abnormality or a microdeletion, most commonly the 22q microdeletion. So there was one study actually where the authors have studied more than 150 babies with aortic arch abnormalities, of which around 33 babies had right aortic arch. So they found, they have used microarray for all the fetuses, and they found that the cases of right aortic arch, 25% of the pathogenic copy number defects or pathogenic microdeletions which are identified using microarray were 22q11 deletions, whereas the rest 75% were some other rare copy number defects. So whenever we see a right aortic arch, even if it is isolated, an invasive testing has to be done, and the test of choice is chromosomal microarray, because this test will tell us even about Down syndrome. It will tell us even about the other chromosomal disorders, and it will also tell us about 22q microdeletions and other microdeletion syndromes, rarer microdeletion syndromes, which can be as significant or even sometimes more severe postnatally as compared to 22q deletion. So a microarray is always to be done. And as Dr. Chaitanya had previously referred, in cases of ventriculomegaly, whenever you have a kind of a syndromic presentation, like you had extracardiac abnormality or you have a positive family history, parental consanguinity, so there is anything else, then we should also keep in mind the possibility of the single gene disorders. At present, we don't have data which tells what is the yield of doing an exome sequencing if you have a right aortic arch, isolated right aortic arch. But yes, we need to further see this, and this is still a kind of an evolving field. So if any high risk factor is there, you could refer the patient to a geneticist to assess their risk for a single gene disorder and whether they need a clinical exome sequencing also, if microarrays come out to be normal.
Thank you. Can you just prognosticate and tell us the outcome of these variants of IRA?
Yeah, so prognostication, actually, the major factors which determine the prognostication, one is, of course, if there is an associated cardiac defect, then often that is what decides the prognosis, what kind of defect that is. So that is one. And if there is an extra cardiac abnormality, then actually we need to be a little bit more concerned, because then this kind of reflects two abnormalities. So there is an abnormality in the cardiovascular system and there is an extra cardiac abnormality. So then this indicates that the baby may be having a genetic syndrome. So here the prognosis becomes relatively guarded. And of course, if you're able to make a definitive genetic diagnosis by doing a microarray or maybe a clinical exome, then in that case, of course, most genetic conditions have a significant postnatal postnatal morbidity in terms of intellectual handicap and various other problems. So that again, the prognosis becomes guarded. But once you have ruled out everything, there is nothing, no structural defect in the heart, nothing extra cardiac, you did microarray is normal, then in that case, the anatomy is what determines the prognosis. So overall, around 25% of these vascular rings are reported to be symptomatic. And here, like what we have seen previously and what the previous my panelists have told, so whenever we have a double aortic arch, then we have a very tight ring. So these cases are quite likely to be symptomatic, and here you would need a postnatal surgical correction. So this is what you need to tell the patient. And then if it is a U-shape right aortic arch with a loose ring, then in this case, you could have a kind of a steel phenomena because of ALSA. And if it is isolated V-shaped ring, so here your babies are going to most likely have a very good prognosis. Only one small thing we just need to keep in mind is that the studies have shown that there could be postnatally detected extracardiac abnormalities still in up to 4% cases. These are usually in the form of gut abnormalities like anal atresia and all, which we cannot pick up on scan. So that possibility remains, but at least you know that you have to screen the baby once the baby is born to look for those things. And then of course, some minor cardiac abnormalities may be there in 5% cases. So again, once the baby is born, the baby needs to be kept under observation for these findings. So this is how, I mean, depending on the findings and the genetic report, we could actually prognosticate the families.
Thank you, Shagun. But one thing is that the gut abnormalities, now we can make out all sorts of gut abnormalities by doing ultrasound. We don't need to wait for the postnatal evaluation, because even the anal atresia can be very well documented by antenatal scans right from 22 weeks onwards. Now, let us get back to Dr. Shlok, because he has presented the two cases. I just want him to summarize the whole learning points, and so that it will be of use to the participants. So, can you please summarize the whole of the panel that we have discussed and we've gone through various aspects?
Sure, sir. Sure. Basically, to summarize, what I can deduce out of this entire panel discussion is that the three vessel trachea view is the most crucial view for the diagnosis of a right-sided aortic arch, and the mainstay is the trachea. That is that the echogenic ring, which side the vessels are, and that is the way we have to differentiate. So basically, a right aortic arch has three types of subgroups. Right aortic arch with right ductal arch forming a V shape, which is very, very often associated with cardiac abnormalities. Then we have a right-sided aortic arch with a left ductal arch, which forms a loose vascular ring in the form of U shape. And then we have a double aortic arch, which is a lambda sign. And in this, the aortic trunk divides into a right and left arch, encircles the trachea and the esophagus very tightly, and beyond that, it joins to form the descending thoracic aorta. 2 points which I would want to reiterate, which are very important, is that right aortic arch abnormalities, the aortic arch, that is a transverse aortic arch, is to the right of the trachea. However, as we go into the abdomen, we see the abdominal aorta is to the left of the spine. This is unlike what we see in situs inversus or isomerism. One more thing, like Dr. Chetan said, a right-sided aortic arch with left ductus arteriosus needs to be differentiated from a double aortic arch, because sometimes the left arch may not be picked up on the standard three-vessel trachea view, for which we may have to slightly angulate the probe obliquely cranially, and then we start seeing the lambda sign. And last, the most important point is that the right aortic arch abnormalities are associated with chromosomal abnormalities like 22q microdeletion and trisomy 21.
Thank
So
you.
these are the salient points. Yeah.
Thank you very much, and thank you for the patient hearing, and I hope this panel was useful in your understanding the embryology of right aortic arch, as well as the various implications that we need to keep in mind while we deal with them clinically. Thank you. Thank you very much.
Thank you, sir. Thank you, everyone.
Thank you very much, sir.
Thank you, Praveen, sir. Thank you so much. Thank you, all the panelists. Khurana, sir. Unmute, sir.
Sorry. We actually had a fabulous panel, and I just realized that there are truly no questions sitting there. So we can happily move on. I'm like, Praveen, you were fabulous. I think this approach to embryology and all the way to genetics and prognosis was absolutely fabulous. I think it was a marvelous panel. Today's panel has been absolutely marvelous.
So it takes us to the last panel of the day. I invite Dr. Meenu Batra to moderate this panel. Dr. Meenu is a consultant radiologist who practices selective fetal medicine in the CMAR hospitals in Edappal and Kochi. She is an excellent orator. I personally love to hear her talks, and she is going to moderate this panel on Meckel-Gruber syndrome. Dr. Meenu, please introduce your speakers and panelists and then move on. Thank you so much.
Thank you, sir. So to set the ball rolling, I would first like to introduce my presenter, Dr. Suhas Kulkarni, who's done his MD radiology from INHS Ashwini Indian Navy Hospital. Well, he was initially working with the JJ Group of Hospitals as a lecturer and later promoted as associate professor. And for the past 10 years, he's been doing his own private practice in Navi, Mumbai. Over to you, Dr. Suhas. You can unmute yourself.
Thanks a lot, ma'am, for the kind introduction. Good evening, teachers and dear colleagues. First of all, I would like to thank Dr. Ashok Khurana, sir, Dr. Praveen, sir, Dr. Bimal Sahani, sir, Dr. Mohisha, sir, for providing us the esteemed platform of SFM to show our cases. With your kind permission, I would like to show my case. A 24-year-old female came to our clinic for second trimester ultrasonography. She was G2. History of consanguineous marriage was present. She had lost her first child few years back. The child had died immediately after birth. No papers or scans were available of that pregnancy. The only thing the parents could remember from that pregnancy was pani kam tha, that's the oligohydramnios, and the baby had 6 fingers in each hand. Coming to the present pregnancy, by her LMP, she was 18 weeks, 5 days gestation. No dating scan was done. No marker study was performed. As soon as I started the sonography, the first thing I noticed was about liquor. The liquor was just adequate, marginally. I started the scan with the head. A well-defined defect was noticed at the occipital region. Brain parenchyma and meninges were seen protruding out through the defect, suggestive of occipital encephalocele. Secondary to the occipital encephalocele, microcephaly was present. However, CSP was seen normally. Both orbits, lips, palates were unremarkable. Scanning further the chest and the abdomen, both fetal kidneys were grossly enlarged and seen occupying majority of the fetal abdomen. Both kidneys were showing multiple tiny cysts in the entire renal parenchyma. Corticomedullary differentiation was lost. Urinary bladder was not seen despite repeatedly scanning the patient over a period of 2 hours. Rest of the abdominal organs were normal. A detailed fetal 2D echo was performed. No cardiac anomaly were seen. Moving further towards the limb, bowing of tibia and fibula were seen. However, the humerus, radius, ulna, every other bones were normal. In addition, bilateral club foot was appreciated. With the presence of occipitaloencephalocele and bilateral large dysplastic kidneys, we had a suspicion of syndromic baby, and hence I started meticulously investigating and looking for the toes, fingers, where I found 6 digits in a hand, suggestive of polydactyly, which was post-axial type. Summarizing the USG findings, we had a baby with bilaterally enlarged cystic kidneys with loss of corticomedullary differentiation, occipital encephalocele, polydactyly, club foot with bowing of legs. Urinary bladder was not seen. No other congenital anomaly was seen. Hence, the possibility of Meckel-Gruber syndrome was considered. Accordingly, the patient was counseled for the same regarding the guarded prognosis of the Meckel-Gruber syndrome. Also, the need for prenatal invasive testing, not just to confirm the diagnosis given on ultrasonography, but also for the recurrence rate in the subsequent pregnancies. As Meckel-Gruber syndrome has an autosomal recessive type of inheritance, the recurrence rate was explained to the patient, which was 25%. That means 1 in 4 children would be abnormal, showing the features of Meckel-Gruber syndrome. Rest 50% will be just carrier without showing any features of GBS, and 25% would be absolutely normal. Despite of all our efforts, patient refused any genetic testing and went to her native place for termination of the pregnancy. At last, take-home message, I would like to emphasize once again, Meckel-Gruber syndrome, earlier thought to be a triad of renal cystic dysplasia, occipital encephalocele, and polydactyly. However, new schools of thoughts are coming up, and they are trying to enlarge or include any other things like nowadays they are considering renal cystic dysplasia along with any other 2 major congenital anomaly that will suffice for the diagnosis of Meckel-Gruber syndrome. While doing NT-scan or early second trimester sonography, an enlarged fetal trunk along with bulky kidneys should alert us, and we should look for other associated anomalies to rule out Meckel-Gruber syndrome. Because of the guarded prognosis of the Meckel-Gruber syndrome, along with the recurrence rate in the subsequent pregnancies, an early, correct, and precise diagnosis will be of great value. Thank you. Now with this, I will pass on the baton to Meenu ma'am for the panel discussion. Thank you, ma'am.
That was excellent, Dr. Suhas. So I would now want to share my screen. Suhas, you can stop. Yeah. Okay, so I hope my screen is visible to everyone.
Yeah, ma'am. Yes, ma'am.
I think I cannot start this panel without thanking the whole SFM committee members and Khurana sir, because each. So before I start the panel, I have to also introduce my team of experts, which includes Dr. Alka Karnik. Madam, well, she does not need any introduction. We all know she's a consultant radiologist and head of the department Ultrasound, Nanavati Hospital, Mumbai, with special interest in fetal and neonatal ultrasound. Next, we have with us Dr. Shailesh G. Sangani, who's professor in HOD, Terna Medical College, Navi, Mumbai. And then we have Dr. Sukirti Jain, who's a consultant obstetrician and gynecologist at Cloud9 Hospital, Vashi, Navi Mumbai, practicing since the last 15 years. We also today have with us Dr. Sachin Nichete, who's a consultant and director of Treetop Fetal Medicine Centers, Navi Mumbai. And finally, we have the problem-solving geneticist with us, Dr. Tanmay Deshpande, who's also MD Pediatrics. He's a consultant clinical geneticist, Sujanan Clinic, Lilac Insights, Mumbai, and also an associate consultant at Mai Mangeshkar Hospital, Pune. So we all know that as far as Meckel-Gruber syndrome is concerned, it is a lethal anomaly. And as Dr. Suhas rightly pointed out, it is having an autosomal recessive inheritance, and it primarily happens because of the dysfunction of cilia and flagella. I know this last sentence sounds like French and Latin, but we will bring clarity to this as we go further in our panel. So coming to the first question, which will be to Dr. Shailesh. Sir, can you please tell us what is the classical triad of Meckel-Gruber syndrome?
Yeah, I'm audible?
Yeah, yes,
sir.
Yeah. So first of all, thank you to the SFM platform, Dr. Khurana sir, Mohit, and Bimal, and Praveen sir, and all. And yes, to start with Dr. Meenu, we will again just revise what Suhas has already told, that these three main things: polycystic kidneys, polydactyly, and encephalocele. These are the three main triad formation. Apart from that, there are many other things, but these three are the main thing. And the prevalence is more in few of the cases are found in Western countries, in Egypt and Syria and all that. So like prevalence is 1 in say 13,000 to almost 14,000, 1,40,000, but it is more common in Gujarati Indians immigrated outside.
Yeah. So as Sir rightly pointed out, as far as the Indian population is concerned, it's important to note that you see it more commonly in Gujarati Indian immigrants. Now, a lot of us see the kidneys at 12 weeks and some of us do not see. But for all of us to know, it is important that at 12 weeks, you will see them as two echogenic structures which are paramedian in location at the either side of the lumbar spine. But what is important, I think, and what I want Dr. Sachin today to tell us is, how do you evaluate the kidneys during an anomaly scan?
Good evening, ma'am.
Good evening.
The first important point we should look for is the presence of kidneys. So we can look for the kidneys in axial section, like in eyes of the owl. We can look them in coronal section along with renal arteries, or we can sweep the baby in longitudinal section for visualization of both the kidneys. The most important point I want to make here is, don't rely on presence of renal arteries only. We have to look for the kidneys directly, otherwise it may be misleading for us. The second is the position. Now, normally kidneys are located in lumbar region, but sometimes they can be ectopic position also. Third is the size. Routinely the measurement of renal size is not recommended. Even just the eyeballing of renal size is more than sufficient. But if we suspect a smaller kidney or if we suspect a larger kidney, then we need to measure these sizes also. Renal pelvis, yes, AP diameter of both pelvis is important to differentiate between mild pylectasis and severe pylectasis. Corticomedullary differentiation is important. It's a picture memory thing. It comes with practice slowly. It is very important to differentiate between the type of cystic kidneys, especially ARPKD, ADPKD, etc. That's how we evaluate an anomaly scan.
Yeah. So as Sachin rightly said, that we do not have to always measure the, but there are certain specific situations where you would need to measure the length. So Dr. Shailesh, can you tell us how do you measure the renal length and how do you assess the echogenicity of the kidneys when, as and when required?
Yeah, the length of kidney is usually measured in sagittal section. We can take it by while we are scanning the spine. Sagittal section, the longest section where the pelvis has to be included in that section, and you have to exclude the adrenal. Sometimes what happens is we falsely include the adrenal, so we have to exclude that. That is the long section. In that same long section, if you want, you can make the probe perpendicular and take the transverse diameter and AP diameter also, the way the AP diameter of pelvis is measured. But for us right now, the long section of sagittal section of kidney is important. And if you want, yeah, if you want, I can just give few rough indicators, like there are good charts by Warren et al. Published in 2005. What you have shown there, it shows a rough calculation of, say, at the 15 weeks, this kidney length is, say, 10 to 15 mm, at 20 weeks 20 to 25 mm, at 30 weeks 30 to 40 mm, and by 40 weeks it is roughly 40 mm to 45 mm. So these are the rough lengths. Enlarged kidneys more than this will be important.
So
now
what
for
about
echogenicity? Yeah, so in echogenicity, generally the kidneys are normally hyperechoic right from the beginning. In the first trimester also they appear hyperechoic. And what happens is the echogenicity has to be compared with the surrounding liver, the lungs, as well as the spleen. Now, we have a good article produced by Ecovics and et al., and which showed a very good correlation of the kidney echo pattern with the pathology. They are correlated with the pathology. So here, what can we move the slide further? We have one good echo patterns showing the kidneys normally. Yeah, yeah, yeah. So what happens is, these are, here we are seeing the enlarged kidneys, and sometimes we are seeing the heterogeneous pattern, as well as we are mottled appearance. Now there have been correlation of this pattern, because kidney, this cystic ciliopathies are most probably picked up early in kidneys, because they are very prominent because of the urine formation after 12 weeks, where the kidney function starts. So it is, liver is also affected, but it's not well seen. So in kidneys, in the first trimester also we can pick up this thing. And roughly what we can do is, like normally they are markedly enlarged, and there are usually demonstration of corticomedullary kind of differentiation, which normally doesn't present in first trimester. Usually it presents towards the 19 to 28 weeks, 20 weeks, but normally it starts presenting early in such kind of kidneys.
We'll come to that later, but important points what we've learned here is renal length is usually done when you're in doubt. And also you have charts available, but then also a thumb of rule which all of us can remember is roughly it will be corresponding to your weeks of gestation. When you're looking at gestation, you will be comparing it with the neighboring liver. And it's also important for you to note the CMD, as Dr. Sachin said here. So the cortex is always more hyperechoic as compared to the medulla. So this is important because in Meckel-Gruber's, what happens is, more than the presence of cyst, the kind of cyst that you see, what you have to notice that there is a complete loss of corticomedullary differentiation that we always need to look at in particular. So Dr. Sachin, since Sir was talking about ciliopathies and stuff, we know from ages ago, we've been following the Potter's classification, but can you also highlight the new classification of the hereditary renal cystic disorders?
Ma'am, theoretically, we divide into ciliopathies and phacomatosis. Clinically, they may not be that relevant. What is more important is what is included into this.
Yes.
So ciliopathies include the most common renal abnormalities, that is ARPKD, which is spongy, large echogenic kidneys, ADPKD, which is slightly enlarged cortex echogenic and cystic kidneys. Third is nephronolithiasis, nephronophthosis. This is a newer terminology. These are the smaller kidneys with cysts and medullary cystic kidneys. In phacomatosis, this is majorly a ectodermal disease that majorly involving ectodermal organs like skin or eyes and all. Sometimes they involve kidneys also, like in tuberous sclerosis, or maybe in
Von Hippel-Lindau syndrome.
Lindau syndrome also.
They're all names which we all
Tongue twisting terminology.
Yeah, we can all go for a tongue twister competition if we learn saying these names. Yeah. So now coming to the second finding, which was another important part of the triad, which is talking about cephaloceles. So in Suhas's case, we saw that there was presence of an occipital encaphalocele. So Alka ma'am, can you tell us how do you classify cephaloceles when we see them?
Yes, Suhas said you have a protrusion which is there. He had an occipital protrusion. So you can classify them depending either on the position of the cephalocele or depending on the protrusion, what you have within the protrusion, what is the contents of the protrusion. So in his case, he had an occipital encaphalocele. So occipital is the commonest position that you have. Almost 90% of cephaloceles are occipital. Then you can have frontal. Both frontal and occipital are usually congenital protrusions, but you can have temporal or parietal ones, which are usually following amniotic bands or some abnormality taking place later on. If you look at the contents of the protrusion, if you have a simple thin-walled fluid-filled cyst, then you would call it a meningocele. If there is brain protrusion seen within occipital lobe is protruded, it will be called as an encephalocele. And if you have the lateral ventricle also protruding within the cephalocele, then it is called as a encaphalocystocele, which is your third picture, lovely picture that you've shown here, showing you the lateral ventricle also protruded within the defect there.
Thank you, ma'am. Now coming to the third feature, he said it was polydactyly, but it is always a nightmare for a lot of us to actually sit and count the fingers. So Dr. Sachin, what is your opinion? Is it really mandatory that we should be counting the fingers every time in each and every case when you're doing an anomaly scan? How important is it?
Ma'am, many institutions, including ISWAC guidelines, do not recommend routine counting of fingers. So I stress the word routine here. Routine means if there is no associated anomaly or any anomaly which has a suspicion of a syndrome, which might involve a finger abnormality, in that case only we specifically should see the fingers.
Yeah, as rightly said, most of the ultrasound bodies will always tell you to only look at the presence or absence of these structures. But when you have an associated abnormality, it is always a good practice that you look at open hands and try to count the fingers. So, Shailesh sir, can you also tell us what are the other features? Because it is not always that we will only see the classical diagnostic triad. Sometimes we might see other features on ultrasound. So can you briefly just tell us what are the other features that you might also see when the Meckel-Grubers?
Yes, so apart from this typical occipital encaphalocele in the central nervous system, we can find the Dandy-Walker syndrome, which we all know is the resultant abnormality because of the non-formation of vermis of cerebellum, or there can be holopresent cephali, like failure of formation of the two lobes of the forebrain, and other microcephaly or anencephaly also. But genitourinary, as we already know, the renal dysplastic kidney is already seen. Apart from that, we can also sometimes find hypoplastic or absent kidney or horseshoe-shaped kidneys. And double ureter is very difficult to find, but can be seen if it is dilated. And of course, external genital ambiguity, but it is very difficult to, and plus with the PCP and DT rule, we don't go into all those details. And hepatobiliary, that is because of the these ciliopathies, the ductal plate malformation means what happens is the biliary tree is not well formed because of the ductal plate malformation, and what happens is there is ectasia and dilatation, and then the cystic changes appear in liver, but they are very later on, not in the early stage, and hence it is there, but rare to find out early, because majority of these fetus, they die in utero in the later stage or very lethal. Skeletal, of course, apart from this, we can get cleft feet or also short limbs, and of course the cleft lip palates and micrognathias or microphthalmia and all those kind of abnormalities. Sloping head is also one important.
We talked about the diagnostic triad. We talked about the procedural malformations. But as Dr. Suhas rightly pointed out, the most common presentation on the anomaly scan is pani nahi hai, pani kam hai, oligohydramnios, and that makes the work even more difficult. So Alka ma'am, when we have a patient with oligo, she just comes and lies on the scan bed. There is no liker around. Of course, the first thought that crosses is, now how will I do a scan for her? But what are the things that you would actually, want to rule out that when you see a patient with oligo?
Yeah, okay. So whenever you put your probe onto the abdomen and suddenly you say, oh my God, this is going to be a difficult one. There's no water. I can't see anything. So first thing you would ask is, have you had any loss of water? Have you been leaking? You look at the cervix. You try and see if the cervix is short. You ask her if she's been losing any, like she'd been leaking. If not, then of course, we know second trimester, early second trimester, kidneys are going to be forming the liker. So we look at the bladder. We can see the bladder 90% of the times. You will see the bladder. Maybe if the baby is just emptied the bladder, you might not see it, but you would see the bladder. Then you look at the kidneys and see if the kidneys are present, if they're present, if they're abnormal or not. And of course, you would look for growth. If everything looks normal, you would see if you do a biometry, look if there's any growth restriction or there's any other cause for the oligohydramnios.
Apart from that, do you think that any investigation with the help of an ultrasound that will help us to evaluate the fetus in detail at this point of time?
Yes, if you can't see the kidneys abdominally and baby's in breech position, you can do a vaginal scan and try and look at the kidneys. Otherwise, you can try increasing the liker by doing an amnio infusion and see if that helps. Even for a cephalocele, you need liker around the head to be able to see a cephalocele. Otherwise, your only finding might be that the head looks small in size. You might not very clearly see a small cephalocele. So you can try amnio infusion to see if you can see the anatomy better. But it's again an invasive sort of investigation. So we can try our best with our good resolution machines. And if not, you can try an amnio infusion, yes.
Yeah. So, I mean, this is just a paper that we actually presented from our institute where we did analysis of 61 cases. We have been doing diagnostic amnio infusion, and we feel it helps us not only in, picking up extra anomalies, but at the same time, it also helps you to confirm leaking, which is a very vague history that most of the times the patients end up giving. They're never very sure of whether they had leaking or whether not. So coming to first trimester, Dr. Sachin, is it possible to detect this anomaly in the first trimester itself?
Yes, ma'am. Actually, in first trimester, the beautiful pictures can be obtained. The reason behind is the presence of liker. Now, the audience must know one thing, that before 17 weeks, apart from fetal urine, there is another sources of amniotic fluid also, like membranes, the majority of the source. So if the kidneys may be dysplastic, may be non-dysfunctional, still the amniotic fluid can be normal. So interpretation has to be proper. The second aspect is we have a tool called the TVS. It's a beautiful tool to evaluate the encephaloceles and the kidneys in first trimester. Third point I want to make is, in first trimester, if the amniotic fluid is normal, the bladder might appear filled also because of the reverse aspiration of the fluid. So interpretation of the kidney findings is important in first trimester.
Yeah. So as Sachin rightly pointed out, we can get some not so beautiful, but some images, as you can see in transvaginal scan, if the anomaly is present in the first trimester. But yes, there's an important point here that if you have a high risk patient or a patient who's had a previous history of the similar syndrome, and you find that the first trimester scan is completely normal, it is also important that you follow up these patients with the same diligence even in the second trimester to rule out the presence of this syndrome. So obviously, when we talk about syndromes, life is never easy. So there is a list of differentials that you would have. And I would like Dr. Sailesh to at least just tell us about the main differentials in brief.
Well, the most lethal, like trisomy 13, has to be ruled out, and then there are little less lethal, like Joubert syndrome or Bardet-Biedl, and all those autosomal recessive polycystic kidney disease. That is the ARP-KD syndromes. And out of this, trisomy is the definitely the main thing we have to rule out. And as we all know that there are various abnormalities in related in the trisomy 13. So I don't think we need to elaborate on that. Do you want me to elaborate?
No, sir, briefly.
Okay, yeah. So everybody knows all those things. So
yeah.
So these are the main symptoms to be ruled out.
Important differentials, but all said and done, the patient lands back to the gynecologist. That's the only person they trust. And so now I have Dr. Sukirti to tell me that this patient comes back to you with this scan report and asks you, what do I do now? And how would you counsel this patient?
Any patient who has been detected with anomaly is going to be very anxious. And the first and the foremost job of an obstetrician is to allay the anxiety of the patient. As you said, the only person the patient trusts is the gynecologist. So first and the foremost is, before actually jumping into the treatment part and telling them about the need for termination and the lethality, we have to allay the anxiety of the patient, tell them, let us find out a solution to this. The second part of it, slowly and gradually, ultimately, you have to involve the partner and the relatives and explain them that this is the 100% lethal anomaly. Either the baby will die in utero or the baby will expire post-delivery, and the maximum survival rate has been reported till 28 months. So second thing is the lethal part. The third thing, of course, if the patient's diagnosis is made before the period of viability, as Dr. Sachin said, that now everybody can diagnose it in 11 to 14 weeks of sonography, because all these anomalies which are detected in MKS are visible by 14 weeks. So we will offer the patient a termination. But before offering the patient the termination, we have to discuss them from the point of future perspective also. And herein comes the role of the prenatal testing. The first part of the prenatal testing will be to check for the chromosomal abnormality. As I read to the chats, many people have asked, why do we have to do a genetic testing when we are already aware this is a 100% lethal anomaly? As has been shown in the last slide, that one of the most common differential diagnoses is trisomy 13. Many of the factors which are sonography findings which are present in MKS will be present in trisomy 13. So how do we differentiate that? So one of the most important part about counseling the patient is that though may it not help in the present pregnancy, but for the future counseling, telling about the prognosis and recurrence, it will be better if the patient goes for karyotyping and detection of any chromosomal abnormality if present. And the second part of karyotyping will be a DNA storage. That means because we're not aware of the full pathology and the genetical part of the anomaly, the DNA can be stored for further evaluation if needed in future.
Yeah. So apart from prenatal testing, is there any other investigation that you would want to perform?
Okay. So once the baby has been terminated, aborted or delivered, it depends on which gestation it was diagnosed. Yeah. What we can do further is a fetal autopsy. As has been shown in the previous slide, sometimes because of oligohydramnios, we are not able to exactly find out the whole picture of the syndrome. If such a patient can be further evaluated by fetal autopsy, we may add on to the diagnostic features which will be helpful in the future diagnosis, prognosis, and reoccurrence. Suppose by the help of prenatal diagnosis and fetal autopsy, it has been diagnosed to be trisomy 13. We know the reoccurrence rate is just 1%, as against the diagnosis of MKS, where we know the reoccurrence rate will be 25%.
Yeah.
Further, it will be helping as an obstetrician. It will help me validate my point of termination of the pregnancy. And regarding the prenatal invasive test, we've already discussed that there are three parts of it. First of all, to do a chromosomal analysis, then to do a DNA storage. And the third thing, there are rare syndromes like the Smith syndrome, which was mentioned in the previous slides, where you can detect the biochemical marker like 7-hydrocholesterol, which I've read in one of the articles, and which can be a pointer as towards that differential diagnosis.
Yeah, thank you, doctor. So, Alka ma'am, it's always very distressing to counsel the patients. And as she said, somebody is asked in the chat box, the easy way out is always to tell them terminate. Ugly pregnancy mein dekhenge. And it is equally distressing for them to actually opt for fetal autopsy because it's a very emotional situation for them. But can you just stress on what is the importance of doing this? How does it really help, even though no matter how good an ultrasound you've performed?
Yeah, you might perform a very good ultrasound, but there can be a lot of technical factors which can prevent you from seeing what you have. First of all, there is oligohydramnia. Secondly, the abdominal wall might be too thick. You might not be able to really see so many abnormalities. You know you want to look for them, but they are not very visible. So with an autopsy, number one, it will help you confirm your findings, what your ultrasound findings are. Number two, it will help you to pick up a lot of findings which you have not been able to see in your ultrasound examination. It will add a lot of information, and that will give you a lot of, it will help you to get to a right diagnosis and help in prognostication, help in telling them about the recurrence rate and about counseling them for the next pregnancy. Then there's some things like facial features and all which you might see better on a autopsy finding, or even the polydactyly. Sometimes you will see it definitely better on the autopsy findings. So it will definitely help from telling them about recurrence of the disease and guiding them for further pregnancies. Yes.
So now we've covered the ultrasound part. The patient has gone through the counseling, and then it's the scariest part, coming to the geneticist. Because 10 years back, if a prenatal invasive test would have been done, life was very simple because we only had karyotype available. But today we have a lot of other options like the karyotype, the CME, the whole exome sequencing. I know Dr. Dhatre did touch on it, but I think we can again ask our geneticist here to explain it once more because it's always Greek and Latin for all of us. So when do we do a KT? When we tell come and do a microarray, or when do we tell them come and do a clinical exome or a whole exome sequencing?
All right. First of all, thank you, Team SFM, for this opportunity. Secondly, it is always very confusing when to order which test, because it is easy to order a test, but to interpret it, to understand, and to then counsel is the important part. So slightly on the microbiology level, a chromosome which is inside the nucleus is basically a coiled and a supercoiled structure which contains the genes. So the deeper the tests that we require, the deeper the differentials that we have, the deeper the genetic tests are ordered. So if we are looking at an aneuploidy or a structural or a numerical defect, we usually go for only on the chromosome level, then we would advise a karyotype. If we want to go on a sub-microscopic level to see the gross deletions and duplications, then we usually go for a chromosomal microarray, which is of two types, high resolution and low resolution. Usually a low resolution chromosomal microarray is performed on the product of conceptus. The deeper the test, that is if we want to go on a gene level test, then if we want to look at the common 8 to 10,000 genes, then we order a clinical exome. If we are looking at the common 18,000 genes that we all know, then we usually go for a whole exome sequencing. And to take the entire panel of 25,000 genes, wherein we do not have any differentials, but we need to go for a diagnosis. We are looking for a syndrome which is not commonly seen, then we would go for the deepest test, that is your whole genome sequencing. So this is basically the deeper the tests that we require, the deeper outlook or insight that we need, the deeper is the genetic test that we would advise.
So you would want to agree with me if I put it as the first line of investigation would remain as a karyotype or a microarray depending on the cost differences. And if we don't land up anywhere with these two tests, then we probably have to think of going to the next step, that is the whole exome sequencing.
Right, that is one good way to put it. But when we have a product of conceptus and we need to isolate the samples, it is always better to go for a chromosomal microarray, because the cell culture for the karyotype is difficult in a product of conceptus. The second thing is when there is a gross dysmorphology seen, and there is a positive, not a positive history, not any specific disorder which is coming into mind, then definitely yes, a karyotype and chromosomal microarray. But we have a strong family history, a consanguinity in question, then usually points towards a single gene disorders, and there you can order a clinical exome or a whole exome sequencing, the NGS tests.
So as I was reading about Meckel-Gruber's, I actually found a big list of genetic mutations involved. And I have not been able to put it on one slide. There are a few that I have put. So can you comment on these, Dr. Tanmay?
Meckel-Gruber syndrome is one of the conditions which has high heterogeneity. So what that means is mutations are at 2 or more loci, and usually they have similar phenotypes. So if you see the chromosomes that are most commonly involved are 17, 11, 8, 12, 16, and recently found out the fourth number as well. So multiple chromosomes and multiple genes are involved. Multiple new tests are coming in, multiple families are coming in, or multiple cases are coming in where new mutations and new loci are found. So that is the reason to pinpoint on a single chromosome or a number of chromosomes or a group of chromosomes is difficult. So that is where the heterogeneity plays part. But known are the 6 common chromosomes, including the 17, 8, 12, 11, 6, and 4.
Yeah. So as I said, we don't like this genetic heterogeneity. So the patient has come to you because we have referred the patient to you. Now, can you tell us what are the molecular tests available? And so we were just talking about KT, microarray and whole exome. So when you have, I am suspicious of a syndrome in this case, yes. So what do? Do we order a focused panel in these kind of situations, or do we just directly tell them go and do a whole exome or a clinical exome sequencing? How do you handle the situation?
Right. So what happens is, as I said, this is a very highly heterogeneous condition, and the more number of chromosomes and more number of genes are involved in here. So mutation screening for an individual gene becomes difficult in this case. So there are panels, of course, targeted panels are available for this test, but multiple labs usually have different panels. Sometimes they may not include some of the differentials as their syndromes. Because Meckel-Gruber is one syndrome which has a lot of very close differential diagnosis, as we've already discussed that again and again in the previous chats and talks. So targeted panels is a good option only if it contains all the major panels that we are looking at. So in a case wherein we do not have a differential, or we have multiple differentials, it is always better to go for a clinical exome with good pictures, good history, and of family history, consanguinity, etc., so that it becomes easier to pinpoint on a variant.
Yeah. So in syndromes like Meckel-Gruber's, where there's a lot of overlap, screening for individual genes would not work at all. Multi-gene panels to a large extent would be able to pick up the common mutations. Yeah. But if you have a family history or a history of carrier in the family, then probably whole exome sequencing would be one of the best options.
Absolutely.
Right? Yeah. So I think we're on the same page, and that's very nice. But I have one more question as a clinician. What happens is, Dr. Suhas explained us that autosomal recessive, the parents are going to be carriers anyways. So now I have a diagnosis of Meckel-Gruber syndrome in the fetus. A very common question that comes up is, why is it important now here that I should also I should do the carrier screening of the parents also? Because anyways, the parents are going to be carriers. So why should I make the couple spend that extra money? Rather than that, I can directly go and do a prenatal CVS for her in the next pregnancy. What is your thought process on that?
All right, so we all know that the mechanism of autosomal recessive pattern is wherein one of the parents are carriers, and 25% of the pregnancies are going to be affected. 50% are going to be carriers, and one of the 25% are going to be normal. So what happens is, when we are getting a diagnosis of a Meckel-Gruber syndrome, many a times we see variants like likely pathogenic and variants of uncertain significance. So here is where it plays very important role to confirm the diagnosis For that, we have to go for the parental segregation analysis to look for a compound heterozygous parent or both the parents being carriers. So in such a case, it becomes difficult, and if that is how you actually determine the genetics of the disease and the disorder and the passage to the next generation. So it becomes easier to counsel them for the recurrence of this kind of syndromes and the chances of recurrence.
Thank you so much, Dr. Tanmay. And so this was a very short and sweet panel, and we've come to the end of it. So major key points or take-home messages that we want to give to our audience today are: we understand that Meckel-Gruber syndrome is an autosomal recessive lethal anomaly with a classical triad. Yes, early diagnosis is possible, but that should not put you off guard, because especially in high-risk cases, you should make it a point that you follow them up in the anomaly scan. Molecular testing is very much important, even though you can make this diagnosis on ultrasound because of the large amount of genetic heterogeneity and the phenotypic variations that are involved. And thank you to the whole team for your patience and bringing out clarity with us. Thank you very, very much.
Thank you, ma'am.
Thank you. Yeah, over to Mohit sir.
Thank you, Minu. Thank you. That was phenomenal. I mean, to make a panel and to create so many questions on a Meckel-Gruber case is just phenomenal. I mean, I give it to you. I just bring this, sir's there. Yeah. You want to say something, sir? Praveen sir, Khurana sir? So you're muted, sir?
Yeah. I think this has been such a fabulous session. And my congratulations to everyone and to Navi Mumbai and Bimal and you for putting this together.
No, I would actually
Marvelous.
request Shlok Dolge, who's actually done all the micromanaging. We were just behind the curtains. He did all the running around. So I would like him to give the vote of thanks to all of you. But I personally would want to thank all the moderators and panelists for making this a huge success. Thank you so very much. Over to you, Shlok. Shlok.
Unmute.
Unmute.
Unmute Shlok.
Unmute, Shlok.
Unmute.
नहीं हो रहा है.
हाँ,
हो गया.
हो
अभी हुआ. Thank you, everyone. I would like to thank our mentor, Dr. Ashok Khurana sir, for giving us this platform. I would like to thank all the moderators, Dr. TLN Praveen sir, Dr. Bimal Sani sir, Dr. Binu Batra madam, and Dr. Mohit Shah, to help us and guide us and take us in through each and every step of arranging this event, which was the first time for New Mumbai study group. So we are really thankful to the entire team. I am equally thankful to the entire panelists esteemed panelists who had devoted a lot of time and gave their valuable suggestions and interacted on the panel discussions. At the same time, I would thank the trade partners, that is the Lilac Insight Lab and GE. I would also extend my heartfelt thank to Conferences International, Sumit Ghai, who managed the entire show flawlessly. And last but not least, Vishal Mittal, who had been the man, who had been the force behind arranging everything which goes behind the curtain. So thank you, everyone. And definitely all the delegates who made this event a success. Thank you very much. Thank you.
Thank you. Thank you so much.
Thank
you. Thank you. Good night, all.
Good night.
See you
Good night,
somewhere
brother.
soon.
Thank you, sir. Thank you.
Be safe. Bye-bye.
Bye-bye.
Bye, sir. Bye.
Bye. Bye.
Bye. Good night.
Good night, Minu ma'am.
Good night, ma'am. Good night, ma'am. Give the